Welcome to the first day of our 3-day SHIP training. If you're a new volunteer, welcome for the first time. If you're an existing volunteer, welcome back. I'm going to go over a little bit of the overview of what SHIP is. If anybody has joined us since we first started this call, if you will please sign in, put your name in the chat here, then we will mark you as attending these events today. We are recording, so if everybody would please remember, if you have any questions, to put your questions in the chat. Please do not unmute yourself and ask these questions. Then we will address all questions at the end of each presentation. SHIP stands for the State Health Insurance Assistance Program. We offer free, unbiased assistance with Medicare. There we go. Also known as SHIP, our program helps Medicare beneficiaries in Tennessee understand Medicare and find the best possible plans available to them right where they live. We offer free, unbiased assistance with Medicare through outreach, education, counseling, and assistance. Who do we serve? We serve anyone over the age of 65 who is eligible or becoming eligible for Medicare, anyone under the age of 65 and disabled who is eligible or becoming eligible for Medicare, any caregivers, any advocates, any family members who are helping to serve this person in their pursuit of trying to get the best possible Medicare coverage that they can. Our outreach, we do statewide outreach in all 95 counties through a partnership with the area agencies on aging and disability and other state and federal agencies, as well as private and nonprofit organizations. We attend health fairs, conferences, group meetings, as well as give general and topic-specific Medicare presentations at churches, senior centers, state agencies, universities, libraries, and many other places. The most common thing that I've heard through my 7 years with the SHIP program, and by the way, my name is Ryan Ramsey. I am the director of the SHIP program for the state of Tennessee. I've been with the program for 7 years, and through that time, the biggest thing that I've heard is, well, we never even knew that y'all existed. And at least in the past, our word of mouth has been our best way to reach our 1.27 million Medicare beneficiaries in the state of Tennessee. That is how many Medicare beneficiaries that we do have in the state of Tennessee. And by doing all of the good work that we do, and by people telling their loved ones, their family members, their friends about our work, we're able to allow people to discover that we're here, we're available, and all the good work that we do. We have our past clients who come and spread the word about our program and the services we offer. We rely on our SHIP volunteers like yourself who serve our beneficiaries all around the state. And we maintain partnerships with local, state, and local programs and agencies to spread the word about Tennessee SHIP and how to reach us. The biggest thing that I would say that we do with our program is education. We help educate Tennesseans about their Medicare. And while I do say Tennesseans, you know, we do have people that call in from other states regarding their loved ones or friends that do reside in Tennessee. SHIP is not specific only to the state of Tennessee. There are SHIP programs for every state within the United States. Hang on, everybody. I'm just gonna try to see who has not muted their phones here and get them muted. If everybody will give me just 1 second.
Fine, come my talking, please.
Hang on 1 second, everybody. I'm gonna have to stop sharing this so I can mute everybody.
Hello.
Okay, I don't hear anybody now, so we'll go back to the presentation. There is a SHIP program for each state in the union, as well as three other ones for locales like Puerto Rico and other areas within the United States. And if somebody does call regarding information about another state, we would just refer that person to that particular SHIP program. Now, not every state calls their program SHIP. For example, Florida is known as SHINE. And my personal favorite is Ohio. They are OSHIP, which is just, you can have a lot of fun by coming up with all the different SHIP names and the use for SHIP within our program. Through our education with older Americans, we offer presentations to the public on Medicare and Medicare-specific topics, such as Medicare Part A and B, Medicare Supplemental Insurance, Medicare Advantage Plans, also known as Part C, how to read your Medicare Summary Notice, Medicare Prescription Drug Plans, or Part D, and then turning 65, what's next? Essentially a preparation for either turning 65 and getting on Medicare, or if somebody is deciding to remain on their employer health coverage until they decide to retire, what their timeline should be for when they're deciding to retire and when they're going to take Medicare. All of these things will be covered over the course of the next few days. So if any of this right here, if you've got a million burning questions on anything in particular, we will absolutely address those soon. Our goal, and I should say that specifically, we are a majority phone call based program. We do the majority of our contact with older Americans through phone calls, and phone calls are what we prioritize in our daily life as SHIP coordinators. Our goal is to empower seniors and disabled persons to make educated choices concerning their Medicare benefits. Our biggest job is providing one-on-one Medicare counseling to beneficiaries, soon-to-be beneficiaries, and their families or caretakers. And by phone calls, that may also be one-on-one counseling, emails, assistance through paper mail, through fax. There's a number of ways, especially in this day and age, that we are able to reach our older Americans and get them the assistance that they need. With our counseling, essentially what we try to do is find the best option for any Medicare beneficiary in the state of Tennessee based on where they live in the state, their plan value, and personal preferences. We are fully unbiased within our assistance on Medicare, and we hold true to that, and we put in the extra effort to make sure that we maintain that unbiased plan that we have for our program. We do not say things like this is the best program or this is what you should go with. Instead, we would say, you know, for where you live and for what you're looking for, this is the plan that suits your needs and would cost you the least overall throughout the year. We're not telling them what to do, or we're not telling them what is best for them. We are telling them, based off of what they're asking us, what is the most cost-effective and covers what their needs are that they're telling us. And the reason why it's based on where they live in the state is that there are different plans for different areas within Tennessee. Not all plans that are available in Knoxville are available in Memphis, and vice versa. So we do have to take where that person is living in consideration, as well as their personal preferences. If we took a poll throughout all the attendees here of what their preference would be about how they would prefer to receive their insurance, whether they would prefer to pay more up front each month and not have to pay as much out of pocket when they go to the doctor, or pay little up front and then worry about paying those copays. Again, I'm hearing some voices here. If everybody will hang on one second so I can mute everyone once again. All right. If we took a poll and you know, I guarantee that some people would say that they do prefer to have that they have everyone. Excuse me. I'm sorry. I got thrown off there by trying to mute everyone. We would have people that would say that they would prefer to pay more up front and pay less out of pocket later, and then we would have some people that said, I prefer to pay little up front, and if I do end up having to go to the doctor, then I'll worry about paying those copays at that time. And neither one of those options is better than the other. It's simply a matter of what that person's personal preference is. And we are not the ones to tell any sort of individual what they should do or what they need to do. We cannot do that. The old adage is you can lead a horse to water, but you can't make it drink. That's essentially what we're responsible for. We can give everyone all the information that it takes for them to make their decision, but ultimately it is up to them to make that decision and make that call themselves. People will ask from time to time, if you were me, what would you do? Or if I was your insert family member named grandmother, grandfather, uncle, aunt, mom, dad, what would you do? Or anything like that. And we have to tell them, I can't answer that. Or I would tell them that they would have to make that call themselves, because we cannot be biased, or we cannot give anybody instructions. And that's simply because if what they choose does not turn out to be what they end up wanting, then they cannot place that blame on any particular person within this program. It is solely based off of what they chose there. Our services are always free and non-biased. We do not charge anything for anybody to come and receive our counseling assistance. We do not sell or recommend any plans. Again, we do not recommend anything, and we do not sell any plans. We do not allow anyone who maintains an insurance license to volunteer within our program or work within our program. We do not partner with any insurance agencies, and we do not even give the appearance of partnering with any insurance agencies. If there is any discovery that someone is working with an insurance agency or referring people to an insurance agent or anything like that, that person will be immediately terminated from volunteering or working for this program. We also serve as a local resource for general Medicare questions. Just because somebody does not know exactly what they're looking for or what they need to ask for does not mean that they cannot call within our program. I have done everything from offer someone, assistance on all different portions of Medicare and do comparisons on all the different options from Medicare to I got the number for Pizza Hut for a lady before. So we are a catch-all program, and we can answer any and all questions for better or worse that come through our program. We do try to assist people either face-to-face on the telephone or via email, whichever works best for them. Currently, due to the pandemic that has been going on, we are not offering face-to-face appointments, nor are we doing presentations out into the community currently. So we've been doing a lot of telephone or email or paper mail for the last few months. We do also screen and provide enrollment assistance for the following low-income programs: extra help with Part D prescriptions and Medicare savings programs, which we will discuss further tomorrow. We essentially, what we do is we screen people based on their income and resource limits to see if they would qualify for those programs, and do everything we can to assist that person in submitting an application to the Social Security Administration for extra help and to TennCare for those Medicare savings programs, respectively. The impact of SHIP counseling and education. Now, this is for 2019 right here. Last year in 2019, we were able to counsel over 118,000 people within the state of Tennessee, nearly 119,000. So that's pretty impressive. It is our highest, if not our highest, it is our second highest year on record for assistance of Medicare beneficiaries. So our coordinators and our volunteers should be commended greatly for all that good work, because it is truly, you know, each and every one of you who makes that possible and does that work. So I commend you greatly for that. And through our outreach and education events, we reached over 137,263 people last year in 2019, which is staggering as well. So it is truly commendable. The volunteer impact within our state. We have 426 volunteers who logged 28,484 hours of service within our program, which makes up just over half of all the hours of service in total within our program. So our volunteers work just as hard as anyone who is a coordinator and works for the program. And it is not lost on anyone. Any coordinator, anyone who works with the program will tell you that what we do with this program is impossible without each and every one of you volunteers who assist with that program. And the dedication and the hard work and the great knowledge that you display all the time makes us successful. And without volunteers, we wouldn't be able to do what we do. Now, the local Tennessee SHIP programs, the way that our state is laid out is that we've got the office that I'm located in, which is the Tennessee Commission on Aging and Disability. And then we've got 9 of our area agencies that cover specific regions within the state. There is the Aging Commission of the Mid-South, which is out of Memphis. There is the Northwest Area Agency on Aging and Disability, which is out of Martin, Tennessee. Family and Children Services covers the Middle West Tennessee area, the Jackson area right there. The South Central Area Agency on Aging and Disability, they cover the lower Middle Tennessee region. Greater Nashville Regional Council covers the Nashville and upper Middle Tennessee area. Upper Cumberland Area Agency on Aging and Disability covers just northeast of that. The Southeast Area Agency on Aging and Disability covers the Chattanooga area. East Tennessee Human Resource Agency covers the Knoxville area. And then the First Tennessee Area Agency on Aging and Disability covers the Johnson City area of the state. If a person calls our program and calls 1-877-801-0044, they get to speak to our call center agents who get their information and sort of a little information about why they're calling, and routes them to their local area agency on aging and disability. So if someone calls from Knoxville, that person will receive a call back from one of the coordinators in Knoxville or in Memphis or wherever that person is located, they get to speak to someone locally within their area to offer them assistance right there. And that is the number that we should be giving out to all of our clients or the general public whenever we're mentioning SHIP. We try to always get everyone to go through our toll-free number and get that information out to the public in that fashion. Now that is the end of my presentation here. I'm going to stop sharing my screen really quickly here. And I'm going to check the chat here. Does anybody have any general questions about the SHIP program or anything that they would like to ask before I turn it over to the next program, or excuse me, the next presentation?
There is a couple questions.
Sure, Lonnie, thank you.
Is there a contact list available for each region's coordinators?
Yes, there is, but we should not be giving anyone, any clients that contact list. Anyone who is calling into the program who needs assistance from another region, we would route them to the 1877 number. But if you just wanted to be able to say, you know, send an email to one of our coordinators in another region to ask them a question or to forward any contact who may have been misplaced and gotten to you, yes, we do have that contact list that your coordinator can provide to you.
Okay, next question. When did SHIP begin in Tennessee?
If I'm not mistaken, I believe it was 1990.
Okay, and the next one. Any idea if in-person contact will resume in the fall?
I'm hoping so, but I cannot honestly give anyone an answer on that right now. You know, I'm in my office full time now. I am one of two people. It's me and our executive director who come in on a regular daily basis. I'm full time back in the office here in Nashville, but I'm hoping that we'll be able to have those discussions and try to get an idea of when we'll be able to resume that. But my hope is that once we can have those discussions and be able to open that up, since we are in the process of phasing back in as a state, that I'll be able to do that as soon as possible, because I know that, for example, some of the more rural regions don't quite have the same numbers when it comes to the COVID-19 as another, and that threat may not be quite as high as it would be, say, in one of your metropolitan areas. So I'm hoping to get that information within the next week or so. You know, obviously with some of the things that have been going on in the city over this past weekend, there was a little bit more attention to that yesterday, but I'm hoping that really soon here we can get back to talking about that, and I can get an idea of when we can get back to addressing going face-to-face and being able to get back to doing outreach as well.
Okay, next question. What is the typical need of a SHIP client?
As anyone will tell you, that could vary quite considerably, but I would probably say, just as a super generalized answer to that question, most of the time it's I need prescription coverage. I can't afford my Medicare, whether that be my premium that comes out of my check each month or my drug costs and premiums, or I'm deciding to retire and need to know about Medicare and what the process is for getting signed up for Medicare, I would say is if I was just to be a good general answer, it's financial assistance, or I need prescription assistance, I need a prescription drug plan / Medicare Advantage plan, or I need to know what is the process for getting signed up for Medicare.
Okay, yeah, that is all of the questions that I'm seeing.
Okay, awesome. Well, what I will do is I'm going to go ahead and turn that over to Angela. Let me get you unmuted here, Angela. All right, Angela, and did you see my email shortly ago about the share button there?
Yes, I did.
Okay, cool. I'm going to go ahead and give you the ball here. You are now the presenter, and I'll let you take it away, Angela.
Great. Good morning, everyone. My name is Angela Ray, and I am the volunteer coordinator for Northwest Tennessee. And give me 1 second to share this. Okay, I believe you should be able to see it now.
Yes, Angela.
Is that right? Okay, thank you.
Yes.
Please bear with me. This is my first time presenting using WebEx, so I apologize. Okay, so today I'm going to cover Medicare's Part A and B with all of you. So first of all, we need to know, what is Medicare? Well, Medicare was first signed into law on July 30th in 1965 by President Lyndon Johnson. Okay, but it didn't go into effect until July 1st of the next year. And we know that Medicare is our nation's largest health insurance program, currently covering about 48.6 million Americans. And Medicare is health insurance for 3 different groups of people. The first group are those who are 65 and older. The second group are people under 65 that have certain disabilities, such as Lou Gehrig's disease, and their Medicare will start without any waiting period. Other individuals that have certain disabilities that are eligible for Medicare, their Medicare will not start until they have received Social Security benefits or rural retirement benefits for at least 24 months. Their Medicare will start the 25th month. And the third group of people who are eligible for Medicare is at any age with end-stage renal disease. Okay, and the agency that oversees Medicare is the Center for Medicare and Medicaid Services. And the majority of people are going to be enrolled by the Social Security Administration for their Medicare unless they have worked for the railroad and are a retiree, and then they're going to be enrolled into Medicare through the Railroad Retirement Board. Okay, as we can see, there are 4 parts of Medicare. The first part is Part A, and this includes the hospital insurance. It helps pay for inpatient hospital stays, skilled nursing care, home health care, and hospice care. The second part that falls underneath original Medicare is Part B, and this is medical insurance. It's going to help cover medically necessary services like doctor visits and outpatient care. Part B also covers some preventative services, including screening tests, shots, and diagnostic tests. Okay, as we look underneath Medicare Advantage, we see that this can include Parts A and B, and usually includes Part D, which is the prescription coverage. You will also hear a Medicare Advantage called Part C. And these plans must cover medically necessary services. However, these plans can charge different co-payments, co-insurance, and deductibles for these services that are different than what original Medicare charges. And then the fourth part is Part D, which is Medicare prescription drug coverage. And this helps pay for outpatient prescription drugs, and they help lower the cost of prescription coverage and protect against higher costs in the future. When someone enrolls into Medicare, they have two different options. The first option is to continue on with the original Medicare, which is the red, white, and blue card, and this will include their Part A and Part B. And then they can choose to add Part D, which is the prescription drug coverage. And they may or may not add a Medigap plan, which is a Medicare supplement insurance. And later on, that we'll go into more detail about Part D and the Medigap. On option 2, they can choose to enroll in a Medicare Advantage. Instead of using their traditional red, white, and blue card, they will enroll into a plan with a private insurance company. These are typically HMOs and PPOs, and they may or may not include that drug coverage. Okay, so how are people enrolled in Part A and B? Most people, if they're already receiving benefits, they're going to be automatically enrolled into Medicare.
Hey, Angela, I'm
Yes.
sorry to interrupt you. Could you hit slideshow and start the presentation? There's a couple of comments in the chat that there's a gray box covering one of the corners, and I think that will resolve that.
Let's see. Okay. Maybe this will work better. Okay, I apologize for that, everyone. Okay, so with the enrollment into Medicare, the Part A and Part B, for those who are already receiving Social Security or retirement benefits, they're going to be automatically enrolled into Medicare, and this Medicare will start the first day of the month of their 65th birthday, unless their birthday falls on the first of the month, and then their Medicare will start the month prior to the first day. If someone is under the age of 65 and disabled, they will automatically get Part A and Part B once they have received 24 months of disability benefits from either Social Security or the Rural Retirement Benefit Board. And they will get their red, white, and blue card in the mail 3 months prior to their 65th birthday or on the 25th month of disability. And on that card, they have the option if they want to keep Part B or not. And there's going to be instructions on what to do if they choose not to enroll in the Part B. And individuals that have ALS will automatically be enrolled the month their disability begins. So the big thing is what to do if you are already not receiving benefits from Social Security and Rural Retirement Board. That means most people, you're going to have to enroll yourself into Medicare. Okay, so if you're not automatically enrolled in Part A and B and not getting Social Security or Rural Retirement benefits, there are several ways that you can enroll. The first is they can visit socialsecurity.gov, they can call Social Security or make an appointment to visit their local offices. And people can apply 3 months before age 65. And if they're a railroad retiree, they can enroll with the Railroad Retirement Board. And there's the local number for that. Okay, so when can they enroll into Medicare? Okay, you have an initial enrollment period for 7 months, and that begins 3 months before you turn 65. It includes the month you turn 65, and is 3 months after you turn 65. It's important for them to enroll during these times, or they can receive penalties for late enrollment. And if they do not enroll within this first 7-month initial enrollment period, they will have to wait to the general enrollment period, which starts in January of each year. Okay, so here is a picture of the current Medicare card and what it looks like. And the new Medicare card mailing has been completed, so everyone should have their new Medicare card that has the alphanumeric code instead of their Social Security number. And if someone misplaces their card and cannot find it, they can always print a copy from mymedicare.gov. And as of January of this year, if they do not have the new card with the Medicare beneficiary ID identifier on there, claims can be and will be rejected by Medicare. So it's important to make sure every beneficiary has their new card. So let's look a little bit more in depth about Medicare Part A, which is the hospital insurance. Okay. For paying for Medicare Part A, most people will not have to pay the premium for Part A, and that is because they have paid the FICA taxes for at least 10 years. Okay, so if they've paid FICA for at least 10 years, the Part A premium is going to already be paid for. Some may have a penalty if they don't enroll when they're first eligible for Part A, and that premium may be up to the 10% or more, and they will have to pay a higher premium for twice the number of years you could have had Part A but did not sign up for it. So if they waited a year to enroll in it past the initial enrollment period, then that means they're going to have to pay that penalty for 2 years. Okay, so let's look at what the 2020 Part A premium is. So if they have paid in the FICA tax for 40 or more quarters, they're not going to have to pay a Part A premium. If they paid it from 30 to 39 quarters, then their monthly Part A premium is going to be $252. And if they have 29 or less quarters, they're going to have to pay $458 a month for Part A. Okay, Medicare Part A hospital insurance covers medically necessary services, and this is including hospital inpatient care. And this is going to cover semi-private rooms, meals, general nursing, and other hospital services and supplies. And this does have a lifetime limit of 190 days. And generally, this is going to cover all drugs provided while they're considered inpatient at the hospital. It also is going to cover skilled nursing facility care. This does not include custodial or long-term care. Once again, it's going to cover the semi-private rooms, meals, skilled nursing, and rehabilitation services. The next category is that Part A covers is home health services. And this covers medically necessary part-time and intermediate skilled nursing care. And it can also include the physical therapy and speech and language pathology, any other types of occupational therapy that they will need. The next category is hospice care. This is for terminally ill and includes drugs, medical care, and support services for the Medicare-approved hospice. Now, the next category is blood. In most cases, the blood that's needed as inpatient will be covered, and you will not have to pay for that underneath Medicare Part A or replace it. So there are benefit periods in original Medicare, measures use of inpatient and skilled nursing home facility services. Okay, the benefit period always begins the first day you're considered inpatient care in the hospital or skilled nursing facility. And it ends when someone has not been in the hospital 60 days in a row. Meaning that if someone went into the hospital today and they leave on Friday, which is June 5th, and during that time they were considered inpatient, their 60-day benefit does not end until August. Meaning that if they go back into the hospital in July, that's going to be, and they consider inpatient, that's still underneath the same benefit period. Okay, so for each benefit period or each 60 days, there is a Part A deductible. In 2019, that Part A deductible was $1,364. And there is no limit to the number of benefits periods you can have. So if they wait and they get out of the hospital, like I said, on Friday, but they don't go back into the hospital until September, their 60 days are up. So they're going to end up having to pay another Part A deductible starting after that 60-day window of time. Okay, here's some examples. We'll look at the first one together. It says, Ms. Smith enters the hospital on January 1st, 2020. She is treated and released on January 15th, 2020. However, she returns to the hospital on February 20th of 2020. Okay, they want to know, is she still within her benefit period? And how many times will she have to pay her Part A deductible? I'm going to give everyone some time to look at that. And I already see some people are answering in the comments. I'm going to give you time to type in what you think.
Angela, looks like everybody's answering once.
Yes, that's what I'm seeing, and you would be correct because she's still in that 60-day window of time. Okay, and let's look at the second one. Mr. Andrews enters the hospital on June 30th, 2020. He is treated and released on July 31st, 2020. Mr. Andrews returns to the hospital on November 15th. Is he still in his benefit period? And I also want to know how many times will he have to pay his Part A deductible. Once again, if you don't mind entering your answers in the chat box.
All right, Angela, looks like majority has said no. He is not in his same benefit period, and he would have to pay his deductible twice.
That is correct. It has been over 60 days since he has been home or out of the hospital, so he will have to pay that twice. Okay, so here is the new information for this year for paying for inpatient hospital stays. Okay, so days 1 through 60, as that first benefit period, the deductible this year is $1,408. So after day 60, so days 61 through 90, it's going to be $352 per day. And then from days 91 to 150, you're looking at $704 per day. And there is this 60 lifetime reserve days in that category. And then all days after 150, they're going to have to pay all the cost of it. Generally, by this time, they are going to probably already been applying for help through the state to pay for these costs, such as Medicaid. Okay, so let's look at skilled nursing facility care. Okay, in order to be in a skilled nursing facility, they have to meet all conditions, and that is they have to require daily skilled services, and this is not just for long-term or custodial care, and they have to have been in the hospital for inpatient 3 consecutive nights or longer, and admitted into a skilled nursing facility within a specific time frame. This is during 30 days after leaving the hospital. And skilled nursing facility care must be for hospital-treated condition or a condition that arose while receiving care in a skilled nursing facility for hospital-treated condition. And the skilled nursing facility must be a Medicare participating facility in order for Medicare Part A to cover that. Okay, so let's look at the cost of being in a skilled nursing care facility. Days 1 through 20, the cost is going to be $0. Days 21 through 100, the cost is $176 per day. And all days after 100, the beneficiary is responsible for all the costs, because Medicare Part A is no longer going to cover the skilled nursing facility care after 100 days. You can qualify for skilled nursing care again every time you have a new benefit period. So that means that, see, once you've been out for 60 days and you go back in, your days start over again. Okay, and we were talking about how Medicare Part A also covers home health care, and there's 5 conditions in order for it to be covered. The first is someone must be homebound. Okay, and the definition of homebound has been clarified for us. And the 2 criteria are the patient must either because of illness or injury need the aid of supportive devices such as crutches, canes, wheelchairs, walkers, the use of special transportation, or the assistance of another person in order to leave his or her place of residency, or 2, have a condition such that leaving his or her home is harmful for their health. Okay, the second criteria or condition for home health care is they must need skilled care on part-time or intermittent basis. The third is their doctor must decide that they need skilled care in their home and has to make a plan for this. The fourth is prior to being found eligible for home health care, doctors must document that they or a non-physician practitioner has had a face-to-face encounter with the beneficiary. The encounter must be done up to 90 days prior or within 30 days after the start of care. This law allows the face-to-face encounter to occur either through telehealth in rural areas or in improved sites. This means medical or other health services given to the patient using a communication system by a practitioner in a location different than the patient. So this has been very beneficiary here lately with COVID-19. It's allowing people to still meet the conditions for the home health care. And the fifth condition is the home health agency must be Medicare approved. Okay, so let's look at the cost for home health care. Okay, it's going to be fully covered by Medicare. The plan of care that the doctor writes up has to be reviewed every 60 days, and this is called an episode of care. In original Medicare, you pay nothing for covered home health care services and 20% of the Medicare approved amount. And this is going to be for durable medical equipment covered by Part B. Okay, and we also said that Part A covers hospice care, and this is special care for the terminally ill and family, and is meant to help people make the most of the last days of life by giving them comfort, relief from pain. It involves a team that addresses their medical, physical, social, emotional, and spiritual needs. The goal of hospice is to care for them and their family and not to cure their illness. They can receive hospice care as long as their doctor certifies that they are terminally ill and probably have less than 6 months to live, and if the illness runs its normal course. Care is given in periods of care, and that's 2 90-day periods followed by unlimited 60-day periods. So that means even though their doctor states that they have less than 6 months to live, their care can go on for longer than that. There are some people that have been on hospice care for over a year. As long as their doctor meets within that time period and renews the hospice recertification, they can stay on that benefit. Okay, so what's covered underneath hospice services? And that's going to be physician and nursing services, medical equipment and supplies, and this is only going to be medication for symptom control and pain relief. And it's also going to cover short-term hospital inpatient care and respite care in a Medicare certified facility. And this can be up to 5 days each time, and there's no limit to times. This is how hospice services come in and support the family by giving them some respite from their loved one. And it also covers hospice aid and homemaker services, social worker services, grief, dietary and other counseling, physical, occupational, or speech therapy. And the counseling goes to help both the beneficiary and their family with grief and loss during this time. So paying for hospice care. There's nothing that has to be paid for the hospice care by the beneficiary, and up to $5 per prescription to manage pain and symptoms and while at home, and 5% for inpatient respite care. Room and board may be covered and this is going to be for short-term respite care or for pain and symptom management. And if you have Medicaid and live in a nursing facility. We said the last category covered by Part A is blood, and this is when you're inpatient. So if the hospital gets blood for free from a blood bank, then you won't have to pay for it or replace it. However, the hospital has to buy the blood. You pay for the first 3 units per calendar year, or you and someone else donates to replace the blood. Okay. Lonnie, can you hear me, ma'am? Okay, we're going to stop here for a second and answer any Part A questions.
I've got this, Angela. Why is there a penalty for not signing up for Part A or B when people are first eligible?
Well, it is pretty much a regulation and law that's written into Medicare stating that you need to sign up in that initial enrollment period. To be quite honest, I wish they would do away with the penalty after a while for Part B. As of right now, that penalty continues on with the person.
To be sure, the reason that they institute a penalty if you don't sign up when you're first eligible is that what they want to do is, you know, at least from a business standpoint, because all insurance is a business. If everybody could just get on or off Medicare whenever they please, then Medicare would lose so much money that they wouldn't be able to keep it up and running at that point. If someone is still working and stays with their workplace insurance, do they need to enroll in Medicare A and B? Will they be penalized for not rolling within the 7 months?
It depends if their workplace insurance is what we call credible coverage. And credible coverage is coverage that is as good as or better than Medicare. Because there are some individuals that keep their employer insurance until they retire, and they are not penalized for that.
Yep. As long as it's credible and there's no breaks in coverage, they can put that off for as long as they need to. I assume this is in regards to the benefit period. Was it 60 days from discharge or 60 days from admission?
60 days from discharge. They have to be home for a consecutive 60 days for that benefit period to end.
And people wanted there were a couple questions. What are lifetime reserve days, and can you explain lifetime reserve days a little bit more?
Okay. From my understanding of lifetime reserve days is that after a certain period of time in the hospital, they give you so many days that Medicare is going to cover. And I'm going to be quite honest with you, I am not as educated on that as I should be. So, Ron, if you want to take that question for me.
Sure. The slide that Angela showed you that said paying for inpatient hospital stays, Angela, would you mind going back? I think it was, yeah, there it is, that one right there. You enter into your deductible once you're admitted into the hospital, and you're only responsible for paying up to that deductible while you're in those first 60 days. Once you pay that off, you meet your deductible, you're good. If you stay past 60 days, you're paying $352 per day, and those are your days that never change. But if somebody remains into the hospital during a particular benefit period and they cross that threshold into past 90 days, then they start eating into what are known as their lifetime reserve days. This third column down here that you see that says days 91 through 150, they are use it and you lose it days. So you only get those 60 lifetime reserve days. You can't buy any more of those. Once you cross that threshold to 91 through 150 days, you have officially entered into your lifetime reserve days, where once you enter into that, you're paying $704 per day. Once you use those lifetime reserve days, they're gone. So if, say, you stayed for 150 days, you got out of the hospital, you remained out of the hospital for 60 consecutive days, and then you went back into the hospital past that point, if you stayed past day 90 again after that first time where you stayed and used up all these lifetime reserve days, this is gone at that point. then you jump from after 90 days, you're paying all costs there. So those are just days that Medicare gives you that if you go past 90 days, they'll pay for those days, but they only give you 60 days during your lifetime. Let's see here. Somebody wanted to clarify when in regards to being into the hospital for 3 consecutive days, specifically 3 consecutive midnights at your hospital, and just stated that those censuses are taken 1 time per day, and you need to make sure at your hospital when the census count is taken so you can be covered if you're needing to go into a skilled nursing facility. Somebody did want to know if you could review what qualifies as homebound. And Angela, I have that pulled up specifically if you just want me to cover that.
If you don't mind, so I don't have to look for it yet.
Yeah, that's perfectly fine. They have clarified more accurately homebound. That would be if you have trouble leaving your home without the help, such as using a cane, a wheelchair, walker, crutches, special transportation, or help from another person. So if you have trouble leaving your home without that help because of an illness or injury, or leaving your home isn't recommended because of your condition, that would be qualifying as homebound. You're normally unable to leave your home, but if you do, it requires a major effort. You may leave your home for medical treatment or short, infrequent absences for non-medical reasons, like an occasional trip to a barber, a walk around the block, a drive or attendance at a family reunion, a funeral, a graduation, or other infrequent or unique events. That would be what would be considered homebound. So just to put it generally, to give everybody something easy to remember, is you're normally unable to leave your home, but if you do, it requires a major effort. Let's see here. Does the doctor get a sum and keep funds when services end shorter if goals are met? For example, hip and physical therapy, the surgeon gets a lump sum for skilled nursing or home health and saves money if they reduce services. Angela, I don't know if you have any insight on that. I certainly do not.
I don't have any insight. From my understanding, it is billed as services are given. So it doesn't seem to me like they, pretty much it sounds like if they, the question is asking if they moved up the recovery period. In other words, does the doctor get somewhat of a bonus for that?
Yeah, I'm not certain about that portion. If a doctor would get any sort of
incentive.
If a beneficiary needs a respite stay longer than 5 days, are the days beyond 5 at full cost for the beneficiary?
From my experience with beneficiaries in the past, that the families were charged after the 5 days, the full amount is what I've seen.
Yeah, that is correct. You're absolutely right. Our Part A premiums free for the first 10 years, 65 to 75, and then from 75 to 77 pay $252, and anyone over 77 pays $458 per month.
Now let me go back to that slide to show you. Okay, this is dealing with how long you have paid in for the FICA tax. So anyone that has paid in 40 or more quarters, their Part A premium is going to be zero, no matter if they live to be at the age of 100. For that 35 years on Medicare, their Part A premium is going to be zero. So these quarters are referring to how long has someone paid into the FICA tax.
Right.
Yes, and there's 4 quarters in a year. So if someone's worked for 10 years, then they have their 40 quarters in.
Yes, if they've made enough each of those years for it to be considered a quarter.
Yes, that is true too.
Mm-hmm.
This question says, if someone has used 10 days as an inpatient this year, 20 next year, 30 the next year, and 30 the fourth year, in year 5, are you entering the lifetime reserve days?
It depends on if those days were after the 60, if it went above into those lifetime reserve days or not.
90.
Yes, yeah, after the 90, yes.
Yeah, and keep in mind that is per benefit period. So if there's more than one admission, inpatient admission, then like if you have one year, you stay 10 days, that's one benefit period. Next year, if they stay 20 days, that's a totally new benefit period. So they haven't really got to those 90 days yet.
Correct. That rolls into what the next question would be, is as so long as you haven't entered the lifetime reserve days during a single benefit period, those are still available.
Correct.
Yeah, correct. But once you do use those, no matter how many benefit periods you have after that point, once you've eaten into those 60 lifetime reserve days, you do not get them back. So if for example, I went into the hospital right now and I stayed in the hospital for 95 days, then for the remainder of my life, I only have 55 lifetime reserve days because I went past that 90 and stayed an extra 5 days and ate into my lifetime reserve days. And let's see here. Medicare was trialing a lump sum program for a certain procedures. Medicare paid a certain amount to the hospital to encourage faster discharge. That was 2 years ago, and honestly, sure, if it was not happening, there were only 2 or 3 procedures this affected. Yeah. Part A premium, that is 40 plus quarters or quarter over their entire working in lifetime. Correct. It's everyone. Someone says that it's cutting out, but unable to hear bits and pieces. Is that a issue for a majority of people? I've been able to hear and see everything fine, so I don't know if that's a issue that a lot of people are experiencing.
She said she called in and she can hear better now.
Okay, cool, great. That is all the questions there, Angela.
Okay. Let me go back to the correct slide.
Oh, wait a minute. One more question.
Yeah, really quickly. Yeah. How can you find out how many?
Go ahead,
Lonnie.
All right, Ron. How can you find out how many quarters they've worked?
If they have a My Social Security account, if they log into that, you can see how many quarters they have worked. I don't know how many of you have a My Social Security account, but I do, and I've gone in to see how many quarters I have, and I think I need 4 more quarters, and then my Part A is going to be covered.
Okay, next question, Angela. how much is required per quarter to be considered eligible to count as a quarter?
So you're putting me on the spot here. I do not have that information with me, but you can look that up on Social Security Administration website, and it will tell you that amount. Are there any other questions?
Angela, I have
No.
found the answer.
Okay, thank
The
you.
amount of earnings required for a quarter of coverage in 2020 is 1,410.
Okay. And that's per quarter?
Yes, that's what it says. The amount of earnings required for a quarter of coverage in 2020 is 1,410.
Okay.
We did have a question, Angela, about will we be able to get the printouts of slides, or is it just at home printing? You can contact your coordinator in regards to that. And that's all that I see, Angela. So you can go ahead and move on to Part B.
Okay, so now we're going to cover Medicare Part B, and this is medical insurance. Okay, just as with Part A, you do have a 7-month initial enrollment period, and that's starting 3 months prior to turning 65, the month you turn 65, and 3 months after turning 65. Okay, and as long as you enroll in this initial enrollment period, there will not be any late enrollment penalties. Okay, so if you have not signed up in that initial enrollment period and you missed it, the next time you can enroll into Part B would be the general enrollment period, and that starts on January 1st and goes through March 31st each year. However, if you sign up January 1st, you're going to have to wait until July 1st for your Part B coverage to start. And the penalty for not enrolling on time is going to be 10% for each 12 months that you're eligible but you did not enroll. And you must pay this penalty for as long as you have Part B. And there's some limited exceptions to this. And that would be if you qualify for an extra help program to help pay for that Part B premium, then the penalty does go away. Okay, the Part B late enrollment penalty is, how does that work with your car insurance is depending on if that insurance is going to be considered credible or not. And we always suggest that beneficiaries contact their employer or union benefits administrator to find out if it's considered credible or not. As I said, the penalty is 10% for each 12-month period. And you usually have no penalty if you sign up within 8 months of your employer coverage ending. So that was a question of earlier, if you will have a penalty if you don't enroll during the initial enrollment period. If you have that employer coverage that's credible, then no, you won't. But you have to sign up within 8 months of the employer coverage ending, or you will start adding to penalties. So here is an example of the Part B late enrollment penalty. Is Mary delayed signing up for Part B 2 full years after she was eligible. She will pay a 10% penalty for each full 12-month period she delayed. So this penalty is going to be added to her monthly Part B premium, which this year is $144.60. So for 2020, her premium will be as follows. You're going to take 20% of $144.60, and that's going to be $28.92. So that's going to be added to the $144.60. So Mary would be paying $173.52 each month for her Part B premium. As you can see, penalties can add up fast, so it's important for us to educate beneficiaries on when their enrollment times begin and end. Okay, some people have to pay more for their Part B premium, and that is based on what they made 2 years previously. And this is due to a cost of living adjustment here. Okay, so let's see, if they reported to the IRS $87,000 or less for a individual, then they are going to pay that $144.60. Once you get above $87,000 for individual or $174,000 for a couple, you're seeing those Part B premiums increase. People are able to get this increased amount adjusted by speaking to the Social Security Administration and having them look at their current income, because most of the time when someone retires, their income is going to decrease significantly. So they may not be making as much as they did 2 years ago. So they can ask for their Part B premium to be adjusted based on their current income. Okay, so paying for the Part B premium, this can be deducted monthly from Social Security payments or railroad retirement payments or federal retirement payments. If this is not deducted because the person is not receiving these retirement benefits yet, then they will be billed every 3 months for their Part B premium. And they can pay these by using Medicare Easy Pay to deduct it from a bank account, or people will have the option of mailing in a check for these premiums. Okay. So let's now talk about paying for the Part B services. In original Medicare, you will pay a yearly deductible for Part B, and that's $198 this year. And then after that, you have a 20% co-insurance for most services. And there are some programs that may help pay these costs. When you look at Part B and employer or union coverage, this may affect the Part B enrollment rights. They may want to delay enrolling in Part B if their employer or union coverage, or if they have that, or if them or their spouse or family member are disabled and still working. And to see how your insurance works with Medicare, you can contact your administrator over your benefits. So when the employer or union coverage ends, they may get a chance to elect COBRA for 18 months, and they may get a special enrollment period of 8 months if their insurance was credible. And if it was credible, then they will not get a penalty for signing up for Part B. So let's see how Medicare and TRICARE coverage works together. Okay. If someone has Medicare and TRICARE for life, they must have Part B in order to keep their TRICARE. Okay. If they're active duty member, spouse, or dependent child, they do not have to have the Part B to keep TRICARE. And you do get a Part B special enrollment period if you have Medicare because you're the age of 65 or because you are disabled. So let's look at what Medicare Part B covers. First of all, it's going to cover doctor services. And these are services that are medically necessary, includes outpatient and some services you get while you are a hospital inpatient, or covered preventative services. Except for certain preventative services, you will pay 20% of the Medicare approved amount if the doctor accepts assignment. And the Part B deductible applies, meaning that they have to pay that first $198 before their cost goes down to that 20%. Okay. Also, it covers outpatient medical and surgical services and supplies. And this is for approved procedures like x-rays and casts and stitches. And they may have to pay the doctor 20% of the Medicare approved amount if the doctor accepts the assignment. And you also will pay the hospital a co-payment for each service. So home health care services, this is medically necessary part-time and intermediate skill nursing care. And this is when they receive durable medical equipment and osteoporosis drug are also covered underneath the Part B, and they will pay nothing for covered services. So let's look at durable medical equipment. This is going to include things as wheelchairs, walkers, oxygen, and hospital beds for use in the home. When you get to the larger items, these items will be covered only if you rent them. And with other equipment, you'll pay a 20% of the Medicare approved amount. And that's only after you meet your Part B deductible. Other things that are covered but not limited to are clinical laboratory services, diabetic supplies, kidney dialysis services and supplies, and I'll let you read the rest. Medicare also covers preventative services underneath Part B. And this, one of those things includes a welcome to Medicare preventative visit and a yearly wellness visit. One thing to inform beneficiaries about is that wellness visit is not like your annual physical. It's more of a hands-off questioning of their current health status and not drawing blood or examining. Because once they get into touching and providing lab services, that is getting into a physical and will not be covered 100% by Medicare Part B. There is a long list of preventative services, and some of these are covered 100% each year. Some are on a certain schedule, such as a routine mammogram for women who are not at high risk. That's only covered every 2 years. So it's important for them to know how often each of these will be covered 100% for them. So let's look at what's not covered by Part A and Part B, and that's long-term care. And that long-term care is going to include medical and non-medical care for people who have a chronic illness or disability. Non-medical care includes non-skilled personal care assistance, such as help with everyday activities like dressing, bathing, and using the bathroom. Long-term care can be provided at home, in the community, or in assisted living, or in a nursing home. It's important to start planning for long-term care for a lot of seniors because that's not going to be covered by Part A and Part B. And routine dental care is not covered, dentures are not, cosmetic surgery and acupuncture is not covered as well. Hearing aids and exams for fitting hearing aids are not covered. At some trainings with Medicare, it was stated that Medicare views dental, vision, and hearing as medically not necessary, is why a lot of these routine visits are not covered. Okay, and if Medicare is not going to cover a service, someone must receive advance beneficiary notice of non-coverage. And this will be provided by the medical care provider when they think that Medicare probably or certainly will not pay for items or services. And this advance beneficiary notice will list items and services that Medicare is expected to not pay for, and an estimate of the cost of the items and services, and the reasons why Medicare may not pay. Are there any questions?
Yes, Angela, the late enrollment penalty is applied to your premiums for the remainder of your life, correct?
Correct. For Part B, it is. Now, Part A, I was just going to clarify that for Part A, it is only twice the amount of time that you are eligible or not enrolled. B lasts for the rest of your lifetime.
Yearly income, I guess in regards to the adjusted premium, yearly income is the same as adjusted gross income, correct?
Yes, from what I've seen while working with beneficiaries, that is what they have reported to me.
Okay. What outpatient drugs are covered under Part B?
Give me 1 second. Trying to find what screen that has that. Hey, that would be like osteoporosis drug is going to be covered underneath the Part B during home health care services. Is one that I see.
In any drug that's administered in your doctor's office or in your outpatient thing, rather than something you pick up at the pharmacy and administer yourself. Is chemo, physical therapy, outpatient considered coverage? Is chemotherapy, outpatient chemotherapy covered?
Outpatient chemotherapy covered. That is, from what I'm saying, that's typically covered underneath the Part B, because a lot of Part B plans do not cover chemo drugs. So it's typically the Part B that's going to cover those.
It depends on what it is. Now, there are some chemo pills, which is actually covered under Part D.
And does Medicare cover insulin pumps?
It does in certain cases. It's covered underneath the Part B. A lot of people do struggle getting the 20% of that covered if they do not receive help through an assistance program or if they do not have a supplement. Because
Yes,
insulin pumps they are not cheap.
Yeah, it does cover insulin pumps. Angela is right there, not cheap. Typically, you are paying what is essentially a rental fee until you own it, and then they will only pay for a replacement after a number of years as well. And buying replacement parts is typically pretty expensive. Let's see here. You pay your copay or deductible for chemo and radiation? Yeah.
Yeah.
If you have a health savings account from an employer, the understanding is you do not need to sign up for Part A and or B until you retire and lose the plan. Is that correct?
Well, not necessarily that. It is a certain period of time that they do not need to contribute to that health savings plan. From my understanding at the training, CMS trainer, they recommend them not to contribute to that for up to 6 months before they enroll in Part A or B, or they can be fined for that.
Yes. If you've got a health savings account, an HSA, you must stop all contributions 6 months prior to taking any portion of Medicare. If you are still working and want to still work, you would need to make sure that your Part A and or B does not start anytime for that, because you will be taxed for any you will be taxed for any contributions you make towards that account once you become, effective on any portion of Medicare. So you have to just make the decision: do I want to stop my contributions and start on Medicare, or do I want to delay all portions of Medicare and keep contributing? Please also, just since we're on health savings account, everyone be aware you cannot use your health savings account to pay any premiums on Medicare. So for people who think, oh, I can just use my health savings account to pay my Medigap or supplemental policy premium, that is not the case. However, you can use it for, copays, deductibles, things like that. There is a lot of questions regarding, Part B covers nebulizers and related meds and everything. There is a Medicare app called What's Covered, where you can search a lot of those specific things. We did have a comment that said chemo radiation, you pay 20% or whatever your insurance states. That is correct. If you were to, say, be on a Medicare Advantage plan, you would pay whatever they set your cost being, but typically under Part B, you're paying 20% of the cost in that situation. What makes certain drugs qualify for coverage under Part B instead of Part D?
Like Lonnie was saying, it depends on where that drug is administered. If your doctor gives it to you in office, that's going to be covered underneath the Part B.
Yeah, correct. Typically where those drugs are administered. Somebody asked, FSA plans are okay though, right? It is my understanding FSA works the same as HSA. You must stop your contributions. If a drug had to be administered by a doctor in their office, then it usually falls under Part B. Part D medications are typically medications that you would get at the pharmacy and administer yourself. What if I decide to go back to work after the age of full retirement?
From from my understanding, is as long as you are enrolled in health coverage that's considered credible, you can actually opt for Medicare Part A and B for a period of time and then re-enroll into it once you leave the credible coverage.
And someone contributed, if you're working and going into Medicare, then your human resources person should become your best friend. It is very good to check with your human resources person in regards to what your current coverage is, what you'll need to do to work with them to make sure you've got all the proper paperwork that Social Security will need, and they're right. You need to check with them first and foremost and make sure that you are getting everything from your human resources person. And then Adrienne said you can't get out of Part A in most cases, but you can drop Part B if you were to go back to work after retirement. Perfect. Do we have any other questions? Okay. Would anyone like to continue on for one more presentation, or would everybody like to go ahead and take our break now? I see a vote. Keep going. One more is good for me. Presentation. Great. One more. Just a quick break. Keep going. Continue on. Okay. All right. It looks like that the majority of people are asking to continue on. What we're going to do is, why don't we go ahead and say that we're going to take a short break. We'll reconvene at, let's say in about 8 or so minutes. It should be 11 o'clock Central Time and 12 o'clock Eastern Time, and we'll knock out one more presentation and then take our longer break, and then we'll get back and do our last presentation and be done for the day. So if everybody wants to take a few minutes break, we'll reconvene in about 8 minutes here. And Angela, I'll go ahead and take the ball back from you for the time being. Oh, okay, everybody, we'll go ahead and resume here. We have about 2 more presentations left for the day. I'm going to go ahead and turn it over to Amanda Johnson. Amanda, if you're ready here, I'll go ahead and give you the ball and get you unmuted here.
Can you hear me?
Yeah, now we can.
Okay. And I'm Amanda Johnson. I am the SHIP coordinator for the East Tennessee region. I'm also the volunteer coordinator. So if anybody, for those of y'all in East Tennessee, I would be your contact person. And this is my first time using WebEx, so bear with me. While I get this PowerPoint going. Okay, are you able to see the PowerPoint?
Yes, Amanda, we are. If you just want to go over to where it says slideshow and start from beginning, then it'll show everything full screen. Straight up from where you are, it's slideshow.
Okay, I don't know why I'm having slideshow.
And then from beginning. There you go.
Okay. All right, thank you, Ryan. All right, so what
You're more
we'll
than
be discussing is the Medigap policies. And these are your Medicare supplement insurance policies. Now, Medigap policies are private health insurance, and they help pay some of the costs that original Medicare does not cover. So remember from the first presentation that Medicare Parts A and B, it doesn't cover everything. So those are the gaps in your coverage, and that's why these Medicare supplement policies are referred to as Medigap policies. So when you hear somebody refer to it as a Medigap policy, you know they're talking about a Medicare supplement. So they fill in the gaps that original Medicare does not cover. So Medicare is going to pay its portion, and then the Medigap policy will go in and will pay what its policy covers. Now, Medigaps only cover one person, so if you have a couple, they'll each need to get their own separate policy. Now, these gaps in original Medicare, what are these gaps? So we remember that Medicare doesn't cover, there's deductibles, and it doesn't cover everything, so you're left with the 20%. So you've got the deductibles, you've got your co-insurance, your co-payment. Now, as long as Medicare, it's a Medicare-approved service, as long as Medicare covers it, then the Medigap policy will go in and pay its share. Now, the coverage depends on which Medigap plan that you buy. And we're going to go over those different plans here shortly. So when is the best time to buy a Medigap policy? Now, you would want to do that during your open enrollment period. So your open enrollment period is a 6-month period where an insurance company has to sell you a plan. They can't turn you down. They can't use pre-existing conditions against you. So it's a guarantee issue period without any medical underwriting. And then the medical underwriting, as y'all probably know, it's the process that the company uses to determine whether they can take your application or whether you have a waiting period or if they're even going to charge you more. So you'd want to get a Medigap policy. This is the best time to buy one is during that open enrollment period. So that period begins when you're 65 and you're enrolled in Part B. So if you're 65 and you're still on a group plan, if you're on another insurance policy and you delay the Part B, then your open enrollment period begins when that Part B starts. So it's not just 65, it's 65 and when you're enrolled in Part B. And you can't change or repeat your open enrollment policy. Some of the states have more generous rules, but here in Tennessee, your OEP is that 6-month period when your Part B starts. Now, you can also try to buy a Medigap policy any other time. There's really no annual enrollment period for a Medigap policy. You can try to buy one, but if you're outside of that 6-month period, then they can turn you down. Now that delayed Medigap open enrollment period, that's what I was referring to when I said if you delay your Part B. So again, because you or your spouse is still working and you've got group health coverage, now this is based on active employment. So if you've got group health coverage and you delayed Part B, that open enrollment period is also delayed. And it's going to begin when that Part B starts. You'd want to notify Social Security, delay the Part B, then you wouldn't have a late enrollment period. So if, for example, someone is 72 years old, they've been working, and now they want to enroll in Medicare Part B. Well, that's when their open enrollment period would start. There are pre-existing conditions and Medigap. We know that pre-existing conditions are health problems that you had before your new insurance policy starts. And these would be treated or diagnosed 6 months before your coverage starts. There's a pre-existing condition waiting period, and this is the period where insurance companies can refuse to cover your out-of-pocket costs for that pre-existing condition. Now, so again, during this period, the insurance company cannot use any medical underwriting to turn you down, but if you do have a pre-existing condition, they can make you wait before they'll cover that pre-existing condition. They can make you wait 6 months before they'll cover that pre-existing condition. There are certain conditions to where they cannot make you wait. There's something called a look-back period. So the coverage for pre-existing conditions can be excluded if the condition was treated or diagnosed within 6 months before the coverage started. So your Medigap policy starts today. If you were diagnosed with something within these last 6 months, they cannot make you wait to cover that pre-existing condition. Now, also, if you've had prior credible coverage, so if you've had at least 6 months of continuous prior credible coverage, and you did not have a break that lasts more than 63 days, then the Medigap company cannot make you wait to cover that pre-existing condition. Now, Medigap plans are standardized, and they're all identified by a letter. A, B, C, D, F, G, K, L, M, and N. Those are your Medigap policies. Now, a company doesn't have to sell all of those policies, but if a company, again, they're standardized. So if 10 companies all sell a plan A, then the plan A, the benefits of that plan have to be the same for every company. Now, the only difference is going to be the cost. The cost will vary between those companies. So again, plans with the same letter have to offer the same basic benefits. Now, you see there's some missing letters in there. There was plans E, H, I, and J. They do still exist, but they're no longer sold. You might talk to somebody who has one of those plans because they were grandfathered in, but those plans are no longer sold. And there's also some restrictions for the C and S plan, but we'll get into that later. Waiver states, Massachusetts, Minnesota, Wisconsin, they standardized their plans in a different way, but we're in Tennessee, so we're not going to worry about that. Here is the chart of the different Medigap plan types. You see on the left side, you've got the benefit, and you see in the box whether or not these plans are covered at 100% or what percentage these plans will cover. So let's look at the Medicare Part A coinsurance and hospital costs. That's a Part A hospital. As you can see on here, all of these plans are going to cover 100% of the Part A costs. So every single one of these are going to cover your Part A hospitalization costs. Now, if we look at the Part B coinsurance, that's when you get a client. In my experience, that's what they're really looking for. They're looking for something that's going to cover that 20%, that Part B coinsurance, and all of these plans cover it to some extent. All of the plans cover the full 20%, except K and L. K covers 50% of it, and L covers 75% of it. You see there's a star on Plan N. Plan N will cover the Part B coinsurance, but every now and then you might get a $20, you might have to pay a $20 copay. And also, there's a $50 copay if you go to the emergency room and you're not admitted, then you'll have to pay a $50 copay on that Plan N. You can see blood and Part A hospice care. Every plan pays 100% of that, except for your plans K and L. They pay some, they pay a lot, but they don't pay all. We've got skilled nursing facility care next. Your plans A and your plans B, they do not cover skilled nursing facility care at all. The Part A deductible, that's the your 1408, $1,408 deductible per benefit period for Part A. The Plan A does not cover that, and all of the other plans cover it, all of it, or at least a large portion of it. The Part B deductible, you've only got two plans that cover the Part B deductible, and that deductible is the $144.60 per year. So you've got two plans that cover it, and those are plans C and F. And again, we're going to go a little bit more into plans C and F here in a little bit. But those are the only two plans that cover the Part B deductible. We'll go down to the Part B excess charges. Plans F and plans G, those are the only plans that cover excess charges. If you don't know what excess charges are, it means so Medicare, they have this preset amount that they're going to pay for a service. So in most states, like Tennessee, a doctor can charge you above that preset amount. They can charge you 15% more than that approved amount. And it's not very common. I've probably seen it twice in the last 5 years. And these are like your specialists. A lot of if someone charges an excess charge, it'd probably be a specialist that would do that. So plans F and G, they'll cover any excess charges. If you're on one of the other plans, the doctor does have the right to charge you that additional up to 15% if they want to. But like I said, it's not very common. If you do have a beneficiary who might be concerned about excess charges, then they can ask their doctors if their doctors will charge excess charges. Some states don't allow excess charges, but Tennessee does. Now down to foreign travel emergency, you see that there are plans that will cover 80% of foreign travel. So a lot of people do look for that. Now, plans K and L, since they don't cover 100% like the other plans do, there's an out-of-pocket limit. So you see plan K has $58.80. Plan L has $29.40. That's the maximum that you would spend. That's your out-of-pocket limit. By looking at the chart, you could assume that a plan A, since it covers the least, they're probably going to be cheaper, and they are. They're cheaper. You see that plan F covers the most. It's like the Cadillac plan. You know that it's going to be the most expensive one. Just like any insurance, the less they cover, the cheaper they are. The more they cover, the more expensive they are. All right, so there were some policy changes with these Medigap plans. It started this year, so January the 1st, 2020. There's a limit on certain Medigap policies for people that are newly eligible for Medicare. So somebody new to Medicare this year, there's some limit on those plans. Remember plans C and F, they were the only plans that covered the Part B deductible. They want everybody to pay their Part B deductible. So plans C and F are no longer sold this year. Now, if somebody has it, again, they can keep it, but they're not selling them anymore this year. So if you're newly eligible, that means that is an individual who, before January the 1st, is neither 65 nor has Part A. Any policy bought before January the 1st won't be affected. Again, if they have a Plan C or a Plan F, they can keep it. If they want one this year, they're not sold. POMCO. POMCO is the state of Tennessee retiree plan, and we get POMCO people a lot. So POMCO, that plan is comparable to the Plan D that you see on the Medicare supplement chart. It offers the same benefits as the Plan D. Now, the premiums on POMCO don't go up due to your age. And we haven't gotten to that part yet, but most of these Medicare supplement plans, your monthly premium will increase as you get older. So POMCO, it does not increase as you get older. So if you get someone that is a state retiree and they may be looking at either a POMCO plan or a Medicare supplement plan, and we don't tell them what they should do, but we do remind them that POMCO is a great plan and your premiums aren't going to go up. If you have less than 15 years of service, the premium is $140.55. As you can see, in between 15 and 19 years, the premium is $115.55. In between 20 and 29 years, it's $103.05. And if you've worked for the state over 30 years, that premium is $90.55. And again, that's comparable to the Plan D. So if someone's on POMCO, their Part B deductible and any excess charges would not be covered. There's a high deductible option, Plan F, and this year the deductible is $2,340. The deductible amounts usually go up each year. They usually have lower premiums, but the out-of-pocket costs would be higher. You might not be able to change plans. There's additional deductibles, and the high deductible plan is not available in all states. Okay. Now, have I been disconnected?
No, I can still hear you.
Yeah.
Okay.
Yeah, you might have gone silent for maybe about 5 seconds, but I can still hear you as
Okay.
well.
My phone is looking a little funny, but it's okay, good. So we're still here. All right. Remember those Medigap plans K and L? Those were the ones that did not cover 100% of everything. I guess this slide is just a reminder that the plan K is going to pay 50%, and the plan L will pay 75%, and they both have the out-of-pocket limit. There is a type of Medigap policy called a Medicare Select policy, and I know that we don't have any in the East Tennessee area, but it is a type of Medigap policy that has a network. And while we're talking about networks, I'll go back. These Medigap policies, there's no network of doctors. As long as the doctor takes Medicare, then they're going to take the Medigap policy. So if you have someone that's concerned whether or not their doctors are in the network, then you can remind them that Medigap policies do not have a network. There's another type of plan that has networks that y'all will talk about another day. But Medigap policies don't have networks. Other than this Medicare Select policy, it does have a network, but we don't have them around here. And we all know that a network means you've got to use specific hospitals and doctors. They usually cost less, and you can switch to a plan with equal or lesser value, but we don't have them here. All right, how much do these Medigap plans cost? So the monthly premium depends on a few things. It depends on your age, where you live, the company that's selling the policy, and some of these companies offer discounts, like if you're a female or if you don't smoke or if you're married. And then also the medical underwriting determines the cost if you're outside of that guaranteed issue period. If you're outside of that open enrollment period, then your underwriting will have an effect on the cost. So the premiums vary greatly for the same Medigap plan. So as I was saying earlier, you may have 50 companies that offer the plan A. The benefits of the plan A have to be the same, but the cost can vary, and a lot of times it does vary greatly for the same exact plan A, depending on what company you go with. So the pricing based on age. So there's different rating types of Medigap policies where the pricing is based on your age. I'm gonna go to the attained age policy first, because most of the Medigap policies are what you call attained age. Most all of them are attained age. And that means the premium is based on your current age. It costs less when you're 65, and the cost goes up each year as you get older. So an attained age policy is going to be cheaper when you're 65, and the premiums will just keep going up as you get older. So the premiums increase based on your age. The other two, the community rated and the issue age, those premiums are not based on, they don't increase based on your age. On the community rated policy, everyone pays the same, regardless of their age, if they're 65 or older. And they're generally least expensive over the lifetime. Now, issue-rated policy is based on the age when you buy the policy, so it doesn't automatically go up as you get older. So the community-rated and the issue age, they usually start out more expensive. So the premiums are higher with those two. The premiums are higher starting out on the community-rated and the issue age, but they don't increase based on your age. So if you have someone that's searching for a Medigap policy and they have an attained age policy that's $100 a month, they need to know that that premium is going to continue to increase as they get older. If they have a issue age policy that starts out at $150 a month, that's more than the $100, but in the long run, it may be cheaper for them to go with the issue age policy. Now, just keep in mind, all three of these policies, the premiums are going to increase based on inflation or other factors. But specifically based on age, only the attained age policy increases based on age. All right, Medigap for people that have a disability or that have end-stage renal disease. So if you're under 65 and you're on Medicare because you've got a disability or you have ESRD, they may not be able to buy a policy until they turn 65. So some states do require insurers to sell Medigap policy to people under 65. Companies may voluntarily sell the Medigap policy, but they're going to cost more. So Tennessee is one of those states where they have to offer a policy for people under 65, but they're going to pay more because they know that they have a disability. They know that their medical costs are going to be more, so they charge them more. Now, if somebody's under 65 and they have a Medigap policy and they're likely paying a whole lot for that policy, once they turn 65, they get a Medigap open enrollment period, so they can get a much, much cheaper policy when they turn 65. So why would someone want to switch Medigap policies? So you may be in one policy and you might want to look at switching to another policy. Why would you want to do that? Well, are you paying for benefits that you don't need? Are you in one of the higher cost plans that's paying for everything and you don't really need that? Or vice versa, do you need more benefits now? Are you in a lower cost plan that doesn't really cover everything and now you need more coverage? But if you don't like your insurance company and you want to change your insurance company or even try to find a cheaper policy, those are reasons in which someone may want to switch their Medigap policy. But there's no guarantee that they'll be able to switch. If you are not in that Medigap open enrollment period, and remember that open enrollment period is at 6 months from when your Medicare Part B starts after you turn 65. So during that 6 months, if you're outside of that window, they can turn you down or they can charge you more for a policy because of underwriting. And then you could have a delay in coverage for pre-existing conditions. Switching Medigap policies, you have a right under federal law to switch during your open enrollment period. Remember, that's that 6 months. So you do have a right to switch during certain times. You can switch during the open enrollment period. Also, if you have a guaranteed issue right, you can switch. And we'll talk about more guaranteed issue rights here in a second. And again, some states have more generous requirements. Some states will let you switch more. Or if you move out of that select policy, if you move out of their service area, you can switch. So again, there's federal laws that will allow you to switch a policy where you are guaranteed to switch, and they can't use your pre-existing condition against you. Now, there's also a 30-day free look period. So if you're on a Medigap policy and you're looking to get another Medigap policy, you can try the other one out for 30 days and see if you want it, if you want to switch, but you still have to pay both premiums during that time. This can only happen when the insurance company will sell you one. So remember that first period where you can buy a Medigap policy without being turned down, that first period is your open enrollment period. Well, there's other situations called your guarantee issue periods. And these provide those federal protections, which in certain situations, you can buy Medigap and they can't turn you down. Pre-existing conditions must be covered and they can't charge you more. So there's certain situations where you can have a guarantee issue, but you have to apply within 63 days of when that other coverage ends. Examples of some guaranteed issue rights. I know we haven't went over Medicare Advantage plans, but that's another type of plan you can go on when you're on Medicare. Let's say John, he's on a Medicare Advantage plan. He has a Medigap guarantee issue right if he joined when he was first eligible for Medicare and within the first year he wants to change. And he has a guaranteed right to switch then. He has a guaranteed right to switch if his plan leaves Medicare or if his plan stops giving care in his area or if he moves out of the plan service area. Other examples of guaranteed issue rights is we've got Mary. Mary's on original Medicare. She'll have a Medigap guarantee if her employer or group plan is ending, but that plan has to pay after Medicare pays. So her employer, group, health plan, or union coverage that pays after Medicare pays, that plan is ending, then Mary will have a guaranteed issue right. Let's say Mary has a Medicare Select policy. Again, we don't have them in this area, but if she moves out of her Medicare Select policy service area, then she would have a guaranteed issue right. So in the, we have it's called Choosing a Medigap Policy. It's a book, very, very useful, and it's got a list of all of these different guaranteed issue periods. The one that I see the most is, well, there's two that I see the most. If somebody starts Medicare, they're brand new to Medicare, and they get a Medicare Advantage plan, and they've been on it less than a year, and they don't like it, their co-pays are too high, they're paying too much, they want a Medicare supplement now. As long as they switch before that first year is up, then they have a guaranteed issue right to go on a Medigap policy. We do see that often. There's guaranteed renewable policies. So Medigap policies that are purchased after 1992 are guaranteed renewable, meaning the company can't drop you unless something happens, like you stop paying your premiums or you weren't truthful on your application or that company goes bankrupt. Some people have Medigap. So remember, if you're on Medigap, you're paying a monthly premium to have this coverage. So they're on a Medigap plan, and then they get approved for Medicaid. And we know Medicaid is you know, they don't have to pay for a premium on Medicaid. They don't have to pay for their services on Medicaid. They're TCAD. So somebody has a Medigap plan, and now they're approved for TCAD. Well, if you have Medicare and TennCare, you generally can't buy a Medigap policy. But you can suspend your Medigap policy for up to 2 years. And then you can start it up again without having any underwriting or any waiting periods. So somebody has a Medigap policy, now they're eligible for TennCare, but they don't want to give up those rights just in case they have to go back on that Medigap policy. They can suspend it for 2 years. If you suspend your Medigap policy, you do not pay the Medigap premiums. But of course, the Medigap policy won't pay any benefits. Now, there's certain situations where you might not want to suspend your policy, and that's if you have Medicaid, if you have TennCare, and you have certain doctors that don't take TennCare. So you may want to keep that Medigap policy so that you can continue to see those doctors. You have a right to suspend your Medigap policy if you're under 65. Let's say you have a Medigap policy, you're under 65, and then you're enrolled in your spouse's or your employer group plan. Then you can suspend that Medigap policy and get it back at any time. You've just got to let them know within 90 days of losing your group plan, and then you won't have a waiting period. So this link is to the premium comparison tool. This is, we use this all the time. We use this tool all the time to look up Medigap quotes. So you would request this from Ryan, and he'll get you a username and password, and it looks up all of the Medigap quotes here in the state of Tennessee. You put in the zip code, you put in whether or not they're a smoker or a non-smoker, whether they're male or female, and it pulls up a list of all of the Medigap policies and their quotes, how much they cost, you know, whether it's an attained age policy or one of the community or issue rated policies. So it pulls up a whole lot of information. So like I said, we use this all the time to look up Medigap quotes. Now, remember, I was saying earlier that these policies, the attained age policies, the premiums will increase as you get older. Well, some of these policies increase at a lower rate. So, for example, you may have a $100 policy, and then you've got a $120 policy. Well, someone would think, well, I'm going with the $100 policy because it's cheaper. Well, that $100 policy may increase their premiums more each year. So this premium comparison tool, it also shows you how much these policies have been increasing their premiums. So you can request that from Ryan once you're volunteer, once you get your volunteer certificate. All right, so that is the end of Medicare Supplement, the Medigap policy. Let me see what kind of questions that we have.
Amanda, I took the presenter from you really quick. I just wanted to show everybody sort of what comes up when we have the tool. If you know, again, once you've completed training and certification and everything, you can request that from me. But if you go to this website, we can run a quote for Medigap policies. I'm getting a little feedback here. Okay, maybe it's just my imagination. What you would do is you would check in. Hang on one second, everybody. Sorry, everybody. What you would do is you would, hang on one second, everybody. I'm going to stop sharing my screen real quick. I'm getting a lot of feedback. Let me just mute all again. Okay. What you would do is just enter a zip code. I'll go ahead and just use the zip code that I'm in right now. It is 37243 here in Nashville. And what it would do is if there's another, if it shows a whole bunch of counties, then that will be in there. You would select whichever county. Let's see, 37221. I think that one opens up. So that's also Nashville, but if you select the county here, or if my computer wants to stop logging so much, then it would give you an option of what all counties do you want to select. I'm just going to select Davidson here. What age is the person? You can see if they're, whoops, go back here. I don't know how that happened. There we go. All right. 37221. I'm just going to leave both of those selected. You can select an age. You can see if they're below the age of 65, then that's the only thing you put is 64, disabled, or end-stage renal disease, what their gender is, are they a tobacco user, and what lettered plan we're looking for. We'll go ahead and just use G right here and say this is a female who is above the, or is 65, does not use any tobacco products, and get quote. And you'll be able to see a lot of what Amanda just told y'all about, is you can see what company it's with, what their premiums are for a month, you know, what their rating type is, attained age, whether it's issue age, community rated. You can see there's a community rated, and Amanda told you that attained age is the overwhelming majority. You can see if I just scroll down here, most all of those are attained age, but attained age starts out at $90.05 for these Plan G. The community rated starts out at $103.07, so luckily it's not too much more expensive than the lowest attained age rated plan. And we get to look at a lot of stuff, but I always like to come right over here to the left side and do the market analytics as well, because it will show you what the increase history is on a lot of these plans. You can see that over the course of about 5 years, on average, this plan increases its premium about 6% per year, whereas this one only increases a little bit less than 1%. And then you'll see on the community rated, there is no you know, age increase on there. There is an increased history because, like Amanda said, it can change due to inflation, but it will not be due to any sort of age-related issue right there. And just Amanda had told y'all that you'll pay more being under the age of 65. You can see here that they start out at about the $100 range. If we were to run a comparison for somebody below the age of 65, they start out at about $282 and go up from there. So it can get pretty expensive pretty quickly here. Now I'm going to go ahead and unmute you again, Amanda, and get these questions for you.
Okay.
Does the waiting period for pre-existing conditions happen when you're outside of the Medigap original enrollment period, or does it apply always?
Now, if you're outside of your open enrollment period, there's no, well, I've never been asked that question before, but I would think that it would still apply.
Yes,
But
the pre-existing conditions waiting period occurs outside of your Medigap initial enrollment period, anytime where you do not have a guaranteed issue rights period.
And that's if the company will take you. So.
Right, but when you're in your initial enrollment period, they have to take you because you have a guaranteed issue rights period.
Right.
For a Medigap coverage, what are they looking for or waiting for during the 6 months of no coverage for pre-existing conditions?
I can't see the questions. I'm sorry. So during the 6 months of the pre-existing condition waiting period, what are they looking for?
Yes.
They're just looking to see if you have any, what pre-existing condition you have. I wouldn't think they're really looking for anything. They're just waiting on until they can cover you.
Yeah, to build off what Amanda's saying, they're looking for a specific condition that in their mind is going to be costly for them. And during that 6 months waiting period, they may cover you, but they will not pay for any sort of charges incurred as a result of that disease or condition at that point. Somebody asked, why are there price differences between these Medigap policies, Amanda?
Different companies they charge different prices. Some companies have different underwriting questions. Some companies, they're harder. You're harder. It's harder to be insured through that company, and some other companies may be more lenient. They may take more people. That's also with your the area that you live in. Obviously, how old you are. Those are some of the reasons and the differences in prices.
Will I receive any more coverage from one company than I will from another under any letter plan?
And if you're under the same letter plan, you will receive the exact same coverage.
Someone must have started Part B Medicare before January the 1st, 2020 to get Plan F, correct? Signing up for Part A alone isn't enough.
Right, Plan C and F. Yes, they would have to have turned 65, be eligible for Medicare prior to this year.
Are plans K and L the only plans with an out-of-pocket limit?
Yes, other than, yes, with out-of-pocket limits, yes.
Yes. And can you go into how those out-of-pocket limits work?
Once you've spent that much money, you don't have to pay any more for services for that year.
Right. So specifically, that's what, $5,880 under Plan K and $2,940 under Plan L. Let's see here. Is there any situation that a POMCO eligible person would not want POMCO? If so, what Medigap would they typically want?
Every now and then we get a POMCO person that does not want POMCO, and we try to talk them out of it without telling them what to do. But so again, we haven't went over the Medicare Advantage plans, but as you can see, these Medigap policies, they're more expensive. Well, there's another type of plan, and they're a whole lot cheaper as far as your premium. So a POMCO person might look at this, $90 to $140 monthly premium and think, I don't want to pay that. I don't see the doctor enough. I'm healthy. I don't want to pay that much. So they might choose one of these other plans that cost $0 a month. But then we go into the benefits of POMCO and the what ifs. What if something happens later in life and you do need more coverage? You've got to get POMCO now or you won't be able to get it later. Also, a person on POMCO who does not have the 30-plus years, their premium would be a little higher, and they may decide to go with another Medigap policy with a lower premium, but keep in mind those premiums keep rising, whereas the POMCO premium won't, and we remind them of that. So those are two situations where I can think of that someone may not want POMCO.
Yeah, like Amanda said, what I tell, in my experience with the program, I've talked to 3 people who've not taken POMCO when they were eligible for it, who did not have an example would be like some companies offer some inside supplemental plan that's different than POMCO that may be better coverage for them than POMCO would be. But for somebody where that's not the case, I've talked to exactly 3 people who said no to POMCO. One person told me that they didn't regret it, that they were perfectly happy, and the other 2 said that they regretted it every single year that they didn't take it. So that is the risk that you run, like Amanda said. And that is for federal, state, federal, and teaching retirees. Let's see here. With medical underwriting, a company can outright refuse to enroll you, correct?
They can,
yeah.
And they will if you are not in your open enrollment or guaranteed issue period.
Right. They also could say, well, we'll give you the 6-month waiting period, but they may also just outright refuse you. And
if they do refuse you during your open enrollment period, then they need to be reported to the Department of Commerce and Insurance.
Yeah, absolutely. If you're outside of that, though, typically I don't have people that call me and say, oh, well, they just said no. What they typically tell me is, well, they told me that I could get a plan, but it was $200 or $300, and I can't pay that much. So, you'll see, if you scroll through that list, that you'll see a lot of different price plans from particular companies, and one company that offers a couple or 2 or 3 letter G plans that are different price, they'll go, well, you don't qualify for our $100 plan, but our $300 plan you do qualify for. So, somebody asked, is Medigap insurance provided by private for-profit companies?
Yeah, these are private companies.
Yes.
Yeah. And is there a star rating for Medigap plans?
They have what are those ratings called? A and best ratings, or it's on the supplement tool, that website Ryan was showing y'all.
I'll pull it right back up
okay.
here. Right here. There we go. A and M best rating, and you'll see, A minus, A plus, AA plus plus, BB plus minus, all sorts of different stuff. So, what differentiates an A minus from an AA minus or anything like that, or an A plus plus or a BB minus or anything like that, I can't tell y'all, but they are ranked like that, and that AM is a company which goes in and essentially investigates and what's the word that I'm trying to come up with? Essentially ranks or scores how stable and how productive any insurance company is. Another thing you might take a look at is how many years in the market do they have as well. That does not, longer does not equal better, but obviously if they've been able to maintain a number of years in the market, that is something that people typically do place a lot of value in. Let's see here. When you say $100 plan, you're talking about monthly premiums? Yes. I'm sorry, I wasn't clear about that. With POMCO coverage for spouses, can spouses' premiums go up over the years?
Everything's going to go up because of inflation, but not that much. Not as much as a typical Medicare supplement plan.
Right. They won't raise it based off their age or anything like that. Right.
And then the question that you asked before that, when you say something about $100, it is a monthly premium, and that sounds a lot. It is a lot. But think about someone who, now remember, they're going to cover the Part B, the co-payment, so that's 20%. So somebody that sees the doctor a lot, or somebody that needs these outpatient surgeries, somebody who has a lot of medical services, that $100 could potentially be a whole lot cheaper than all of their out-of-pocket costs.
For a deductible.
Right.
Yeah, I mean, the Part A deductible alone is more than what you would pay for a full year of premiums under the lowest costing letter G plan. So even if you went with AARP, which is the lowest priced community rated, that's not going to go up based off your age, that's $103.07. That's just over $1,200 a year. If you went into the hospital and had to pay out your full Part A deductible, you would end up paying more a year than you would having that premium plan all year. So especially for people who have a lot of doctor bills, it can save them a lot of money. But some people say, well, I just want to pay for the safety net. I know if I ever go into the hospital, I'm not going to be slapped with a big old medical bill.
Yeah, and that deductible is per benefit period, so you could be saving a lot more than the $1,408. So yeah.
Any chance with the current economic environment that they might bring back F for 2021? I am in no position to say anything like that, but I would not bet that would be very likely.
I agree with you.
Yeah. Community rate does not go up due to age, but it goes up if the medical cost per year goes up, which it does most years. Thank you, Sheila. Like, for example, POMCO, when I started 7 years ago, it was about $86 a month, and now it's up just shy of 90, so it's gone up, maybe $3 or $4 over. So are you saying that a Medicare supplement plan covers the deductible for a hospital stay? Hang on one second here. Amanda showed y'all this chart right here earlier. If you'll see right here, Part A coinsurance and hospital costs, Part B coinsurance, Part A hospice coinsurance, Part A deductible right there. So essentially with a Medigap policy, what the benefits are is you pay a higher premium, but you have little to no out-of-pocket costs. So yes, a Medicare supplemental plan does cover the deductible for a hospital stay, with the exception of like a Part A, yeah. Part A is the only one that does not cover your Part A deductible. Or excuse me, not Part A, Plan A. I need to be very specific because Medicare does use Part and Plan in a lot of things. So it's a Plan A Medigap policy does not cover that. Anybody else have any other questions? Okay. Well, we'll go ahead and take our lunch break. Why don't we say let's meet right back up here at, let's see, what time is it right now? 12:02. Why don't we meet up at 12:45, come back, and we'll get started with our last presentation of the day. No, come back at 1. Lonnie has suggested we come back at 1, so why don't we do that? Okay. Well, I will see everybody back here at 1 o'clock then.
Coverage, and now that depends, how it's paid is going to depend on whether it's under Part A, Part B, or Part D. That's going to depend on medical necessity, the healthcare setting, so whether it's outpatient, inpatient, in your own home, things of that nature, medical indication, so why you need the prescription, and any special drug coverage requirements, such as immunosuppressive drugs following a transplant. I recently had some fun with that. So, yeah, those can be categorized differently depending on these factors. Now, mainly we're talking about original Medicare today, although you, of course, can get prescription drug coverage through Medicare Advantage plans. All right, so Part A prescription drug coverage generally pays for all of your drugs during your covered inpatient stay that's given as part of your treatment, whether you're in a hospital or a skilled nursing facility. You do see the one exception there, certain chemo drugs when you're in a Part A covered SNF stay. Also drugs used in hospice care, but as mentioned earlier, that's only for pain relief or symptom control. It's not to cure or to make anything better as far as your actual condition. But if you're in hospice care for pain relief, that will be part of your Part A prescription drug coverage. Now, Part B is generally for outpatient drugs, and I know we had a question earlier about which ones. So, again, injectable and infusible drugs. So some examples would be drugs used to treat anemia that's administered at the same time as chemotherapy, or injectable osteoporosis drugs. Try saying that 5 times fast. Also, if it's something, however, if it's something that you can administer yourself, even though it's a shot, then that could be under Part D. But typically, these injectable drugs, for instance, I have an aunt that's got to get B12 shots at the doctor's office, so that would be mainly under her Part B drugs. Drugs and biologicals, especially used for the treatment of end-stage renal disease, that's under your Part B as in boy, your medical insurance. Drugs used at home with some types of Part B covered DME, so nebulizers and infusion pumps, the prescriptions that you have to put into those devices will be covered under your Part B. And then there are some oral drugs with special coverage requirements, some certain oral anti-cancer and anti-emetic drugs, some immunosuppressive drugs, but as I mentioned before, some of those may be Part B, may be Part D, it just depends on the circumstances. So those are some of the things that would have it come under your medical coverage as opposed to your hospital or your standalone drug plan. Now, the immunizations, many of those are also going to be covered under your Part B, your flu shot, your pneumococcal shot. Yes, I pronounced it, your pneumococcal shot, so that's the one for pneumonia, hepatitis B shot, and then certain vaccines after exposure to injury or disease like the tetanus shot, I believe the rabies shot also. So those would often be covered under your Part B for medical. And now let's get into D as in drugs. Okay, Medicare prescription drug coverage. So these are drug plans that are approved by Medicare, but they are run by private companies. So when I'm counseling people, whether on the phone lately or face-to-face, that's what I tell them. You know, when you have original Medicare, Medicare is your is your insurance company as it is, but the drug portion, that is a private company, so Cigna, Aetna, those folks, but they are contracted by Medicare, and they are available to everyone with Medicare. In most cases, you have to join a plan in order to get coverage, and the two ways that you would do that would be through a Medicare prescription drug plan, a PDP, or you might hear me say standalone drug plan, and then also Medicare health plan, aka Medicare Advantage plan, that has prescription drug coverage bundled with it. Most plans do, but not all, so that's something to definitely be on the lookout for if you have someone who wants drug coverage and they're looking at an Advantage plan. Again, most of what I'm going to be covering pertains to original Medicare. Some things do overlap, but you'll get much more detail on the Advantage plan portion tomorrow. Medicare prescription drug plans can offer different combos of coverage and cost sharing. They have to offer at least a standard level of care of coverage set by Medicare. They are going to vary. People often ask what's the difference, and I'm like, well, heck, your premium for one thing. So they're going to offer vary in terms of costs, as well as which drugs they cover, and how they cover them. As you see here, different tiers and or co-payments and or co-insurance. Someone asked me the other day, so this drug is a tier 1 on my plan, so it's a tier 1 on every plan, right? Not necessarily. So that's going to vary from plan to plan. And benefits and costs may change each year. They can go up, they can go down, so that's going to be different from year to year. In 2020, most people will pay a monthly premium. Again, as I mentioned, that's going to vary. A yearly deductible. Most Part D plans that are standalone do have deductibles. There are a few that don't. Most people will have co-payments or co-insurance. The percentage of the cost, your percentage of your cost may change once you get into the coverage gap, or you may have heard people refer to it as the donut hole, and that begins when you and the plan together have spent $4,020 on your prescriptions. That can happen easily if you have expensive drugs or if you just have a laundry list of drugs. Then your percentage goes down once you get into what's called catastrophic coverage. So once you're out of pocket $6,350, you're in the catastrophic coverage. And I think it's because if you've spent $6,350, it's a catastrophe. So you're in catastrophic coverage. All righty, so just as you heard mentioned when we were going over Part B about the IRMA, the income-related monthly adjustment amounts, that applies with Part D as well. That's going to be based on income, and in fact, you'll see in the chart that it's the same income levels that we saw before. So fewer than 5% of folks pay a higher premium, because fewer than 5% of folks make good money. They use the same thresholds as you would see in Part B. The income is going to be what's reported on your tax returns from 2 years ago. This is required as long as you have Part D coverage, and if you don't pay, you'll be disenrolled. Uncle Sam is coming to get his, folks. And that extra amount does not go to your insurance plan. It goes to the Medicare Trust Fund. The coverage gap, we'll get into that in a little more detail, but as I mentioned before, I'll go back a slide because I did see that pop up just real quick. So the coverage gap starts when you and the plan have paid retail cost of drugs at $4,020. So once you've hit that level, you'll go into the coverage gap. But like I said, we'll do that in a bit more detail in just a sec. All righty. So this chart should look somewhat familiar, at least the first half of it on the left side. So those income levels are what we saw before. And this is based on your income. This year, it would be your income tax returns from 2018. And if you go all the way to the right, you'll see what your increase in premium is. Because the Medicare Part D premiums are different, they can't, of course, like they do with Part B, tell you flat out, bam, this is what you're going to pay. So we have to have a surcharge and then whatever your premium is for whichever plan that you've chosen. So let's say you're like most of us in the $87,000 or less for single folks and $174,000 less for people who file joint and are happy to file joint together and they're married. You're not going to pay a surcharge. Just whatever your premium is what it is. But once you get to that next category, you can see we're starting at $12.20. I want to point out that is per person. So even if you are filing jointly and therefore they're considering your income together as a couple, the surcharge is still going to be individual. So she's going to pay $1,220, he's going to pay $1,220, or she and he, whichever. It's going to pay $1,220 extra once you're in that second category, and so on and so forth throughout the chart. You can, as Angela mentioned earlier, if you feel that this is unfair or your circumstances have drastically changed, you can try to petition for equitable relief. You would do that with Social Security. They have a form for that. You can contact them when they're back in the office and get that form. You can find it online with some searching. Contact SHIP, and we should be able to dig that up for you. But you can try to file for equitable relief. One reason someone might do that is, let's say 2 years ago, you got a insurance settlement, so it bumped your income up. Your income was never that high entire life. It's just that 1 year because you were unlucky enough to have that car accident with that guy, but fortunately he had insurance, so you got a settlement. So you might be able to hopefully petition them by saying, look, this is not indicative of what my life has been. I had a car accident. And so you might be able to get some relief that way. It's not a guarantee, but that is one way you can go about trying to see if you can get that IRMA dismissed, or at least get a lower IRMA. Alrighty, so in the coverage gap, aka the donut hole, so what you would pay once you enter the coverage gap. It has improved, as you can see, in 2019 for brand name drugs. Once you got to the coverage gap, your co-pay or co-insurance would be 25% of the retail cost, and your generics would have been 37%. This year it's 25% across the board, which is a significant improvement from what it was years past. And so this, you may have heard people say, well, I thought the donut hole was closing. It's basically bringing it down to this 25% level, and that's where it's going to stay. So that's how that works. Now, your true out-of-pocket costs, these are expenses that count towards that threshold that would get you into the catastrophic coverage phase. So these are the costs that's going to go towards that $6,350. So once you, as I mentioned before, once you get into catastrophic coverage, your co-payment for your drugs goes down drastically. I believe it's 5%. It goes down to 5% rather than the 25% you were paying during the donut hole. And how you can keep up with your true out-of-pocket costs. When you have a drug plan, you're going to get an explanation of benefits showing the claims that you've made over a certain period. So it should let you know and calculate and keep adding for you as you progress how much you've been paying throughout. Even if you switch plans during the year. So for some reason you left, let's say, SilverScript and went to WellCare Medicare Select, they're not going to say, oh, well, you're with a new plan, forget you. No, they're still going to keep your true out-of-pocket costs calculated. And also, this thing here at the bottom, talking about what the pharmacists have to do. They have to tell you if a better price is available without using your plan. So we're going to get into that in a bit more detail also. But if you go to the counter at Kroger and they recognize that, ooh, she's going to pay that using Medicare, heck, we can get it to her for like half the price. They should let you know that you can pay cash and get that lower price rather than going through your insurance. So those are things going towards your true out-of-pocket costs. Now for Part D covered drugs, again, it covers both brand and generic. Now in order for it to be covered, first it has to be approved by the U.S. Food and Drug Administration. So, you know, those natural supplements you get at GNC, if it's not an FDA approved drug, then Medicare is not going to cover that. It has to be used and sold in the United States. So none of these, well, they sell it up in Canada, and I had a friend, wink, wink, send it down to me. Well, if they don't sell it in the U.S. and use it in the U.S., Medicare does not cover that drug. Also, they have to be used for medically accepted indications. So basically what that means is if this drug claims that it's to be used for XYZ purpose, but you're using it for ABC purpose, typically they're not going to cover that. This includes prescription drugs, biological products, and associated supplies, such as those associated with insulin injections. The plans must cover a range of drugs in each category. So what that means is, let's say you have a category that's got 5 drugs in it, they've got to cover a good range of that. Not maybe all 5, but a good range in that category. And the coverage and rules will vary by plan. So Plan A might cover this many in that category. Plan B might cover the same number, but shift it over to different ones in that category. So what's required coverage? If it's a drug in any of these 6 protected classes that you see on your screen, they must be covered. All drugs in these classes must be covered, as well as commercially available vaccines like the shingles shot, unless it's something that's covered under Part B. So yes, flu shot is commercially available, but that's still your Part B. And make sure that you go to Kroger and show your red, white, and blue card for that flu shot. But otherwise, it would be under your Part D, like shingles. What's excluded by law under Part D would include drugs, as you can see here, anorexia, weight loss, or weight gain, ED drugs when it's used for the treatment of sexual or erectile dysfunction. If it has another purpose that is medically indicated, they might go for that, but if it's for this particular purpose, not going to happen. So that guy who called back after he left because he didn't want his wife to know, they showed up in person together, but he called later and was like, oh, ma'am, I left off on my list. I left off Cialis. Okay, I'll check it. Not wanting your wife to know. And no, it was not covered. Fertility drugs are not covered. And you can see the rest of these, cosmetic or lifestyle purposes. Cough and colds. Dude, if you got a cold, just get some NyQuil. Otherwise, Medicare is not handling that for you. Prescription vitamin and mineral products, mainly are not covered under Part D, as well as over-the-counter drugs. So when people tell you they take the baby aspirin, just go, okay, but that won't be on the list, but okay. Now, how plans manage access to those drugs? We have these 4 ways that they manage that. First, we have our formulary, which I find I usually just tell folks the list because most people don't know what the word formulary means. But this is the list of drugs that each plan will cover. So if you're using a drug that's off the formulary, that could be a problem. Prior authorization. So some drugs, and this is going to vary from plan to plan, some drugs you have to get authorized by your insurance company before they'll pay for it. And your prescriber is the one that would normally contact the plan to get that approval. And again, it has to show medical necessity. You're not taking it just to be taking it, but the doctor has shown that, yes, you do need it. Yes, it's for a medical purpose. And in order to get that drug covered, just don't go out to CVS and pick it up and expect Medicare to cover it, Medicare drug plan, if it's not prior authorized for those particular drugs. Then we have something called step therapy. So sometimes a plan will say, hey, I know that your doctor said you need this brand name drug, but we prefer you to try this little generic first and see if it works, because if so, awesome sauce. If not, okay, fine, we'll go up the chain and see, and then maybe your doctor knew what he was talking about, and go up to the step therapy drug. And then we also have quantity limits. So there are some drugs that a plan will place limits on. So for instance, they may say for a 30-day period, you can only get 60 of these. Or for a 90-day period, you can only get 120. So your prescriber, your doctor can try to get an exception made for that if they feel it's medically necessary. So that's going to be between your doc and the plan to hash out. Now, formulary tier. So this is what I was mentioning before about tier when I was talking about, is it always a tier 1? Not necessarily. So drug plans, most of them are going to have these 4 tiers. Some have 5 on there, or what they call a specialty tier. But as you can see, as you go from the lowest number to the highest number, that's also how your prices are typically going to go, from the lowest copayment to the highest. As you can see, most generics are going to be in the tier 1 category. In tier 2, you're going to see either preferred generics, or you might see some preferred, non-preferred generics, or some preferred brand names will be in tier 2. Tier 3, this is where you typically will get brand names. Depending on the company, it may or may not be preferred. And then your tier 4 or higher, this is where this is either a non-preferred brand name, or it's a specialty drug, or it's one of those brand new drugs, and they cost a whole arm and 2 legs in that tier, typically. Formulary changes. So when can the plans make these changes? In most cases, they can only change categories and classes at the beginning of the year. They make maintenance changes during each year, as you can see. Now they are supposed to give you 30 days notice when they are going to make these changes, or when you request a refill, they should give you at least a month's worth since they're making this change, so that you can kind of have time to maybe get with your doctor and make a change, but at least you'll have this drug right here. Because, you know, a lot of times you hear on TV where they say, don't stop taking this drug until you've talked to your doctor. So to give you a chance to still be on the drug until you all have a different plan in place. You may be able to continue to have that covered until the end of the year, or your doctor may be able to ask for an exception if they figure out that other plans just won't work and therefore they need to keep you on this. I had a person come in, and that was this person's case, was that they tried the generic, and as she told me, she looked like a pizza afterwards. So the doctor had to write an exception saying, you don't want her to look like that, let's go with this one. And so they did write the exception. So that is a possibility. And they did write the exception for the remainder of the year. And then, of course, she switched plans afterwards. Plans may immediately make changes without notice or at any time if they're going to remove a brand name drug and replace them with generics, but they have to meet certain requirements in order for them to do that. Also, if a drug is considered unsafe by the FDA, then they're going to remove it, which is probably not a bad thing, because if it's going to kill you, why would you want to pay for that? And then, or if the manufacturer itself removes the drug from the plan, then of course they can just yank it without notice because it doesn't exist anymore. All right, so new formulary changes. Plans can immediately remove or change the price of a brand name drug if they add a therapeutically equivalent generic drug on the formulary that's going to be the same or a lower cost tier, or it's going to have the same or fewer restrictions. If the generic drug becomes available after the plan submitted its formulary. These plans have to submit their formulary to Medicare in early fall, so I think about September, October sometime. They have to submit that to Medicare. Well, you know, let's say February comes up and some genius comes up with a generic. This gives them the opportunity to now add that to their list and say, hey, we're going to cover this, and we didn't know about this at the time that we said we're covering only these drugs here. They do need to notify all of their plan members and prospective enrollees of the change. So prospective enrollees, as in, you know, you signed up in October, they figure out this change in December, so you're not technically on the plan yet, but they know you're on the list, so you're one of those who needs to know. So you and plan members need to know. They have to provide advance notice to CMS, as we heard earlier. Those CMS is the entity over Medicare, and other specified entities before they make the sub, and they directly have to notify any affected enrollees of such a change. Now, how plans manage unsafe use of opioids, you know, it's all over about how unsafe these drugs are. They've become more and more prevalent. So healthcare organizations, Medicare, all of them are doing what they can to try to stem that tide and keep people from addiction or curb addictions or help people with them. So here's some ways that they manage unsafe use of opioids. There are drug management programs. If you get opioids from multiple doctors, prescribers, I should say, and pharmacies, then your plan may have a talk with them to see that you make sure you really need them. You know, in some cases you might. There are people who do have 5 different doctors, and they may have been prescribed something different by each of them. So the plan is going to check it out to make sure that this is legit and not just you basically doctor shopping trying to get these prescriptions. If your plan decides that your usage is not safe, they may limit your coverage and place you into this program. They'll send you a letter, and they'll let you know about the appeal process. So you always have the right to appeal this decision, you or your prescriber. You know, again, if they're like, look, I know you think that she's taking 1 more per day than she should, but this is her case, this is what she's going through, the woman needs 4 a day, not 3. So you can appeal that, or your prescriber can appeal that. But just know that these are ways they're trying to make sure that you are using it legitimately and safely. There's also safety reviews at the pharmacy. You go to the pharmacy and they think something's going on, potentially unsafe amounts. Found that out by accident. My dad had a surgery and he was concerned that the pharmacy was going to close on Sunday before I could get there. So he asked me to pick up a prescription on Saturday. And I got there, and Randy, our very nice pharmacist, was like, so Mr. Franklin isn't due for a refill until tomorrow? And I'm like, yeah, but we didn't think I'd make it in time tomorrow to get it. Oh, okay, you sure? Yes, Randy, I'm sure. You've seen me for 6 years. Okay, fine. So he let us have it, and he said, but, and I was like, yeah, don't do it again. I told Dad, dude, we're just going to have to make it on Sunday next time, because they will check you out for that, which I suppose is a good thing to make sure it's not being used unsafely. If your pharmacy can't fill a prescription, they'll issue a notice explaining that you or your prescriber can contact your plan in order to get a coverage determination. Another way for an appeal. All right, so then there's medication therapy management. So they can do a comprehensive review of all your meds and talk to you about how they're working, whether or not they have side effects, any interactions between your drugs, whether or not your costs can be lowered, other problems you're having. So this is something that could be beneficial to people. I haven't had any direct experience with that with anyone that I've spoken with, so feel free to chime in if you all have more details about how that works. Now, in order to qualify for these services, you do have to meet all of these conditions. You have to have more than one chronic health condition, take several medications. So if all you're taking is the one, that's not going to work. And your meds have to have a combined cost of more than $4,044 per year. Oh, and I see it says these can be conducted by phone. Okay, cool. Elimination of gag clauses. So the Know the Lowest Price Act of 2018. So this is a law that was signed in 2018, and yet most of the stuff hasn't really moved until this year, January 1st, 2020. But anyway, this prohibits drug plans, Medicare drug plans, from restricting or penalizing a pharmacy for disclosing price information to an enrollee. So remember when I was saying earlier how you go to Kroger and they look at it and they're like, dude, you can get this for half the price if you just pay cash. Used to be they could not say that. So now they're no longer going to be penalized if they say that to you. It allows pharmacies to disclose the difference between the negotiated price and the lower price without using any health care coverage. As I mentioned before, the law was signed in 2018, but the legal requirement didn't really apply to plans until 2020. And you can choose to pay cash, and you can still submit that claim to your plan so it can be calculated for the true out-of-pocket cost going towards that $6,350, you know, to get you towards the catastrophic coverage if you think that you're going to be in that range. And also to see if you can get reimbursed for that too. You can submit that claim even though you've paid cash at the pharmacy, so keep your receipts. Now, Part D eligibility requirements. You must have Part A or Part B to join a Medicare drug plan. So I often get people who think they have to have both. No, you just have to have one or the other. And sometimes, unfortunately, that's how people get themselves into trouble as far as enrolling late. They had A, they didn't have B, they didn't think they needed to have D, tis autumn. So yes, as long as you have A or B, you can join a Medicare prescription drug plan. Now, if you choose to get your prescription drug coverage through a Medicare Advantage plan, because that is another way to get your drug coverage, then of course you have to have both A and B, because you can't get an Advantage plan without both. Again, more details on that from somebody else tomorrow. You must have Medicare Part A and Part B, or only Part B in order to join a Medicare cost plan with Part D coverage. We don't really have cost plans here in Tennessee, but I think we do have a little bit of verbiage on that coming up later. You have to live in the plan's service area. So if you live, say, in Fayette County, make sure that we're putting in the right zip code to get you that plan, because even though Fayette is still in my area, for those who don't know, we do Shelby, Fayette, Tipton, and Lauderdale. If I look them up and make an accident of putting in Shelby when it should have been Fayette, because we do have a couple of zip codes that overlap, I may pull up a plan that only covers them if they're in that zip code portion that's really in Shelby and not the portion that's really in Fayette. So definitely make sure you are in the plan's service area in order to have that plan. You can't be incarcerated, so just because the penal farm is in Shelby County doesn't mean the penal farm is in the planned service area. You can't be incarcerated. You cannot be unlawfully present in the United States, so you have to be a citizen or a legal resident. And you can't live outside of the U.S. So if you're living abroad, the good life in the British Virgin Islands, you can't have a Part D plan. Now, if you move to St. Thomas in the U.S. Virgin Islands, you can, but not when you're outside of the United States. And you must join a plan in order to get drug coverage in most cases. Now, creditable drug coverage. So this is what they were speaking about earlier when they were talking about Part B. It applies as well to Part D, that if you have what's considered creditable drug coverage, meaning that it's going to pay on average as much or better than Medicare's standard drug coverage, then you may not have to enroll in a Part D plan. So some creditable drug coverage will include group health plans from an employer. Also, it can even be from a retiree plan. Now, in most cases, retiree health insurance is not usually considered creditable for Part B medical, but in many cases, it is creditable for Part D, your prescription drug plans. And of course, you want to always make sure of that by having it in writing that it's creditable. VA, TRICARE, Indian Health Service, and federal employee health benefits, all of these would most likely qualify as creditable prescription drug coverage. They do have to inform you on an annual basis whether or not it's creditable, and that does need to be in writing. So this whole, going by the copy machine and going, hey, Cynthia, it's not creditable this year. No, you need that in writing. Anytime you have a lapse of 63 days or more in creditable coverage, you may have to pay I am reading that wrong. When you have a lapse of more than 63 days, thank you, of creditable coverage, you may have to pay a late enrollment penalty when you enroll in prescription drug coverage through Medicare. Potential losses of other coverage. If you have coverage through other insurance, say from your employer group health plan or your spouse's health plan, retiree plan, PACE plan, all those other ones, if you have a loss of coverage, then you may be able to join a drug plan without penalty, but you want to take some things into consideration. If you do have that other coverage and you're not losing it, it's still in place, and you're thinking about getting a drug plan at the same time, you should speak with your plan administrator to make sure that you can have both, because that's not always the case. If you sign up for a drug plan, it may cancel the coverage that you have. For some people, that's what they were trying to do in the first place, so cool. But for others, that's not what they were trying to do. So again, check with your plan administrator to see how your current coverage works with Medicare prescription drug coverage, especially if you have a plan that's covering other people besides yourself. Because if you go into something and you get canceled from that plan and your dependents don't have any other way to get drug coverage, probably not going to be that happy with you. So you want to make sure that you're making the best decision for yourself and possibly for any dependents if you have drug and health coverage that's covering these extra people. And in many cases, you might not be able to get that coverage back. I know with a lot of retiree plans, once you cut it, you cut it. So again, definitely speak with them about the rules and make sure you get that in writing too, so you know that what they're speaking is actually what's written. So check with your current plan before you enroll in a drug coverage plan. Now, your initial enrollment period, 7 months. This is your third time hearing it, or fourth, I don't know, but this should be cemented in your head. If it isn't, it will be by the end of the day. So you have that 7-month initial enrollment period. So this applies to Part D as well as Part A and B. So that is the 3 months before the month that you turn 65, the month that you turn 65, as well as the 3 months after you turn 65. So this is when you can enroll into prescription drug coverage, whether or not it be a standalone drug plan or a Medicare Advantage plan with drug coverage. This is when you can join during your initial enrollment period. And just like with A and B, when you sign up is going to determine when your coverage begins. So when you do it the 3 months prior to your birth month, it's going to be eligible the day that your Medicare is eligible, which is usually the first day of your birth month. The only exception to that is if your birthday is June 1st, then your first eligible is actually May 1st, so that's when it would be. But for everybody else, if you're born the 2nd through the 31st, then it's going to be the first day of your birth month. If you sign up during your birth month, then it's going to be eligible the first day of the following month. And if you sign up those 3 months after, it's going to be delayed 2 to 3 months. Now, we do have other enrollment periods for prescription drug coverage. The big enchilada for us, of course, is the yearly open enrollment period. We've been told to call it the annual enrollment period. I just say that thing that happens in the fall. So October 15th through December 7th of each year, you can make changes to your prescription drug coverage. And if you do so, those changes will be effective January 1st. And that's regardless of whether you get your coverage through a standalone prescription drug plan on original Medicare or a Medicare Advantage plan with drug coverage. So you can make those changes during that period, and it will be effective January 1st. Now, if you are in a Medicare Advantage plan, once it hits January 1st, you now have another bite at the apple. So from January 1st to March 31st, you can make coverage changes to your drug coverage. This is only available for people who are already enrolled in a Medicare Advantage plan when the clock strikes 12 and it's January 1st. Then you can make these changes. You can switch Advantage plans where you either add Part D or drop Part D, because like I said, not all Advantage plans have B. You can, and it says Part D is not guaranteed, again, unless you were in an MA plan on January 1st. Now, this is not available for people who are in original Medicare with a standalone prescription drug plan. So if you have original Medicare and WellCare Medicare Select and you don't like it on January 1st, so sad, too bad, unless you get extra help, and that's a whole nother discussion. But in most cases, you're going to have to wait. But if you're in a Medicare Advantage plan, you can take advantage of this 3-month period. If you don't have Medicare Part A coverage and you enroll in Part B during the general enrollment period, then you can sign up for Medicare prescription drug coverage April 1st through June 30th. So as Angela mentioned to you before, that general enrollment period for people who missed the boat and now they're going to go get their Part B. They didn't get it when they had the ability to, but now they're going to get it during January 1st to March 31st. You don't sign up for the drug plan then. You sign up for the drug plan April 1st to June 30th, and it's still going to be effective July 1st, just like your Part B will be. Special enrollment periods. So there are some exceptions to everything that I just said in the last 5 minutes. There are certain life events that will allow you a special enrollment period where you can make changes to your drug coverage outside of those periods that I mentioned. So, for instance, you permanently move out of your planned service area. So, no, you're not going to the vacation beach house in Florida for 3 months. You're permanently moving to the vacation beach house in Florida. So that's when you're going to want to make a change. So you will have a special enrollment period. If you lose other creditable prescription drug coverage, so for instance, you lost your job, whether on purpose because you retired or they let you go, then you'll have a special enrollment period, or your spouse, if you're getting it through your spouse, same thing. You're losing your coverage that way, then you're entitled to a special enrollment period. If you weren't properly told that your other coverage wasn't creditable, or they reduce it, so remember when I told you they have to let you know in writing whether or not your coverage is creditable. So if they didn't do that, you find out later it wasn't, and it's made you enter a late enrollment penalty, that's a problem. And so that's something you can bring up as, hey, I'm entitled to a special enrollment period. These people didn't do what they were supposed to. Or let's say in 2019 it was creditable, but for whatever reason they did something, and in 2020 it's no longer creditable, so it's been reduced. So because of that, you have a special enrollment period. If you enter, live at, or leave a long-term care facility, so when you go into a nursing home, a long-term facility, I should say, then you have a special enrollment period, the duration that you're there. Or if you leave, you know, they finally decided, hey, we're going to bring me my home, so that gives you a special enrollment period. If you belong to a state pharmaceutical assistance program, we don't have that animal in Tennessee, but if you have a friend in some other state, you can let them know that they have a special enrollment period if they belong to one of those. If you decide to join or switch to a plan that has a 5-star rating, if I'm not mistaken, there's only one plan that does that in Tennessee, and that's a Medicare Advantage plan. If I'm not mistaken, there are no Part B 5-star plans. But there is one Medicare Advantage plan with a 5-star rating. So if you decide to switch to that particular plan, you can do so throughout the course of the year, but you can only take advantage of that once, only one time. If you qualify for extra help, you can make quarterly changes in the periods you can see on the screen. You can make that change the first quarter, the second quarter, the third quarter. The reason we only have 3 quarters listed, if you make that change during any of those periods, the coverage will be effective the first of the next month. But if you make that change from October through December, well, you're in the annual enrollment period we were going to have anyway, and so that change will be effective January 1. And then there can be some other exceptional circumstances. So if you fall into any of those categories that would be considered way out there, then you might be able to get a special enrollment period. For instance, if you lose Medicaid, you know, you had it and whatever, somehow you got a bump or maybe a trust fund came in, I don't know, but you lost Medicaid, then because you're being kicked out of extra help, they give you a special enrollment period to go find a plan that you got to go pay for now. Oh, speaking of extra help, so extra help dual and partial dual eligible SEP limitations. So previously, they could change pretty much any time during the year. So they could change in January, February, March, April, May, you know the calendar. But as of Jan 1, 2019, they changed that to make the changes only on a quarterly basis. Now, these folks will have another SEP, as I mentioned earlier, that exception. If they lost or gained or had some sort of change in their Medicaid or extra help status, they get a 3-month special enrollment period. And they do have to be notified of this, of course, by CMS or the state. Extra help dual and partial dual eligible individuals who are considered to be potentially at risk or at risk for misuse of certain drugs like those opioids, they won't be able to use this. So as we were talking about those ways that they try to safely manage opioid usage, so if they feel that someone who's getting extra help, or they may be dual eligible, if they feel that they may be misusing a particular type of drug that's deemed unsafe if not used the right way, they can take away that privilege of being able to change quarterly. Some more limitations. You have the CARA Act that was established. They established those drug management programs. You can't, heck, I just said that. You can't use the extra help or dual eligible SEP if they consider you at risk. I do believe you can appeal that, and if you're successful, awesome. But otherwise, if they consider you at risk, then they're going to limit what you can do. Of course, you do still have the annual enrollment period. That's not taken away. And if you qualify for a special enrollment period for all of those other laundry list of reasons that I just went over, you're not disqualified from that either. You would just be not have the ability to make those quarterly changes based on your extra help or dual eligible status. And now for the fun, the late enrollment penalties. So you've heard about this with Part A, you've heard about it with Part B. Well, folks, we have it with Part D also. You may have to pay more if you enroll late, meaning you missed your enrollment period, your initial enrollment period, or if you didn't have a special enrollment period in which you could get drug coverage. So, or if you lost coverage, you know, you didn't pay your bills, your premiums, they yanked your coverage and you had to wait several months, they're going to count those. So that's when you would get the late enrollment penalties. So the exceptions to that would be, of course, if you do have creditable drug coverage, then you aren't supposed to have a penalty when you do finally get into a drug plan, if ever. And if you have extra help, then they waive that penalty. The penalty is for as long as you have coverage. So if you have coverage for the rest of your life, then yeah, it's for the rest of your life. But as long as you have coverage, you have the penalty. Now this fun math is 1% for each full month that you were eligible, but you did not have creditable prescription drug coverage. And they're going to multiply that based on a beneficiary, base beneficiary premium, which changes every year. This year is $32.74. So if the base premium goes up, your penalty is going to go up. If it goes down, it's going to go down. So each year they recalculate that base beneficiary premium. But just know the math is the same, 1% for each full month and you did not have creditable prescription drug coverage. So for some folks, this is going to be just a couple of dollars. I have a couple of church members, that's what happened to them. They went without, they missed it by like 14 months. They just didn't know to do it at the time that they got Medicare. So they missed it by about 14, 15 months. So they're paying about a couple of dollars more per month. They can afford it, trust me, they've got nice cars, but it's the principle that matters, and they're not happy about it. But for some people, this can get to be really expensive. I also know of a lady whose mom was 92. She had excellent health, awesome, and but when she got to be 92, that started to change, as one might expect in many cases. And so she was looking into getting her a drug plan. Well, by the time we calculated how many months that would be, she was like, there might be another route I can take that would be cheaper. And that's going to depend, of course, on finances, resources, and all of that. But it can get expensive the longer a person goes without having creditable prescription drug coverage. Now, things that people need to consider before joining a plan: do you have other current health insurance? So as I mentioned before, the reason it's important to consider that is just in case joining a Medicare drug plan is going to make you lose that coverage and that's not the result you want, that's something you need to consider. Or if the other drug coverage you have is frankly just cheaper, why the heck would you want to go this route? Is any prescription drug coverage you might have as good as Medicare drug coverage? How does your coverage work with Medicare? You know, maybe it's not going to cost you too much to have both, and they won't kick you out, so you want to see if that's something that's feasible, so that's always a good thing to work out. And could joining a plan affect your current coverage or a family member's coverage? So again, for you, it might, if you were by yourself, it might be the best thing to only have Part D, but it might be awful for your spouse or, you know, any dependents that you have. So that's something that you want to definitely sit down between you, the family, the plan administrator, and the computer and figure out what works best for you. But these are questions that you should consider before you make that decision. New members can expect certain things. Your plan's going to send you the card, an enrollment letter. They're going to send you membership material. So there should be a book in there that lists your formulary. It should list all of the pharmacies that are in network, whether they're preferred or standard and all of that. It should give you their contact information. Very likely will tell you what to do if you want to pay, you know, do mail order or something like that with the plan. So you should get an awful lot of information from your plan. Now, if you do have a drug that's not covered by your plan, as I mentioned before, oftentimes you can get a transition supply for 30 days. You should work with your doctor, prescriber, I should say prescriber because it could be an NP. You should work with your prescriber to find a drug that is covered. And if there isn't an acceptable alternative, see if you can get an exception. So in some cases, it may just be a matter of the prescriber typically prescribes, you know, one drug, but the next one will do just fine, and they don't think it'll wreck your health, so they go ahead and make that change. Or it could be, yeah, it will wreck your health, let's not make that change, and they work on trying to get you an exception. Now, annual notice of change. All drug plans are supposed to submit this to their members no later than September 30th. So you may get this in the mail or email if they have your email address, but it is supposed to be sent to you in writing if there's going to be any changes in the upcoming year to your drug coverage. So they need to let you know what their benefits are, what changes there would be, if they're changing the formulary. For instance, with my dad, they sent him a letter a couple of years ago letting him know that they would no longer do Invokana, so he had a choice to go with one of the other drugs of its class or to get a different plan. So, but that allowed him to make that decision because he knew up front from the annual notice of change. Also, if there's going to be any changes to the premium or the cost sharing, or the deductibles also. I know SilverScript had a change where it used to be zero deductible across the board. Then last year they changed zero deductible for Tier 1 and 2 and $350 deductible for all your other ones. So any information like that, they are supposed to send that to you in writing. They're not supposed to just let that sneak up on you. So you do need to read that carefully. So if you're counseling anyone, encourage them to not automatically put it in file 13, please open it and read it, because 9 times out of 10 when I speak with people and they go, I didn't know, I asked them, did they send you something? Oh yeah, but I just thought that was a, they sent it. But you know, every now and again, maybe not. But they do need to read that carefully and compare and make sure that's something they want to continue with in the upcoming year. And if not, that's a good time to make some changes, which is why we have our annual enrollment period in the first place, so they can see what options are available to them. Alrighty, so enrollment periods. At the top, our open enrollment period or annual enrollment period, or that thing that happens in the fall, October 15th through December 7th. Again, your coverage will start January 1st. They start marketing these plans on October 1st. In fact, I just had a person who was way ahead of the game asking me if they could see plan comparisons because they were going to be turning 65, I think, in February. And I was like, well, I mean, if you really just want to see what we're doing this year so you know what it looks like and how it works, sure. But if you actually want something that's going to be beneficial to you, you should wait until October, because that's when we'll actually have the information for 2021. The non-renewal special enrollment period. So if your plan is not renewed, for instance, we had a plan here a couple of years ago called Magellan. We don't anymore. So that plan was not renewed. That contract with Medicare was not renewed. So that gave people a special enrollment period from December 8th to the end of February. So they were able to make changes even after the annual enrollment period, because their plan was not renewed, and because they didn't read their mail, and they called me on January 3rd and said what happened to my plan, so I had to help them get into another one. When they do make the change, the coverage is going to start the first of the month after they've made the change, the request. And if they don't make a change by December 31st, they will lose Part D. So, yeah, definitely want to check your mail, definitely want to call your SHIP office and see what you can do if you find out that they're going away. Medicare Advantage open enrollment period, I mentioned before, so I won't belabor the point, but again, first 3 months of the year, January 1st to March 31st. Or, as they mention here, your first 3 months after your initial Medicare entitlement. So you turn 65 in June, you actually have those 3 months afterwards, July, August, September, to make a change for your Medicare Advantage plan, because you're still in that period. Or if that's when you got disability also, it's your 25th month of disability, so you were initially entitled. You've got that 3 month period. And so when you make that change, your coverage will start the first of the month after that request is made. And this is if you picked a Medicare Advantage plan, let me say that. So let's say you were gonna turn 65 this month, June 6th, and you were an early bird, you came in April, and you picked an Advantage plan, and then, you know, after your birthday, you're like, what the heck did I do? I want out of this thing, or I want a different thing. So you will have 3 months, that July, August, September, where you can switch to a different Medicare Advantage plan or go back to a Medicare, original Medicare, and get a prescription drug plan. So that's after your initial entitlement to Medicare. Also, again, I mentioned that 5-star enrollment period. So if there's a 5-star plan that you want to get into, you can enroll into that plan. It will be effective the first of the month after you make that change. You can only do that once per year. If you have, if you're dual eligible or have extra help, as I mentioned before, you've got 3 periods through the year that you can do it, and your coverage will begin the following month. If you do it the last period of the year, October through December, then again, it changes on January 1st. And then other SEPs, the time is going to vary depending on what your issue is that entitles you to an SEP. That's going to vary. I will say this, I'm always very careful when I'm speaking with people who are currently working or their spouse is currently working, and they are going to, they know the date when they're going to retire, so they know, and they usually know that they have the 8 months to get Part B, but what a lot of them don't know is you only have 2 months to get the Part D. So I always try to stress that, because I did have a lady who unfortunately tried to enroll in Part D 4 months after she lost coverage because she retired. And she was good with Part B, but for Part D, I was like, sorry, ma'am, you're going to have to wait till the annual enrollment period. So other special enrollment periods, there are different time periods for different circumstances. So it's always good to find out what that circumstance is and make sure we're given the right information about how much time a person has. I know you never thought that this would happen, but I am at the end. So we'll open this up for questions or tomatoes being thrown, whichever suits you.
Adrienne. We had a couple of questions come in. Is the shingles shot covered under Medicare Part D?
Yes. I know there was some question about which shingles shot, so I can't speak to the brand names, but shingles shots are supposed to be available under Part D.
Yes, and then the new
Yes.
one that I believe just came out is covered, in fact, by Medicare.
And those actually have to be given to the beneficiary at the pharmacy.
Yes.
If they're given in the doctor's office, they have to check with their doctor's office to see if the doctor's office can bill their Part D plan directly.
Right.
If not, they could be having to pay the entire bill. Just a caveat.
Somebody asked if you could go over the coverage gap again, please.
Okay. Let me see. Let's find that slide. Okay. So the coverage gap. Okay, let me back up, although I don't have this up, but just imagine, if you will. So you have a plan. Most of them have a deductible period, so we'll start there. So if you have a plan that has a deductible, then you're going to first start out in your deductible phase. So you're going to pay whatever price that plan has negotiated for your deductible period, which often is the full price, not always. But whatever price they say you're supposed to pay during the deductible period, that's what you're going to pay. Once you are out of the deductible period, you go into the initial coverage phase. So during the initial coverage phase, you're going to pay a certain amount. This amount actually can be 25%, but sometimes it's less. But whatever the heck they put it in, that's the price you're paying during your initial phase. Now, if your drugs, retail, ever hit the point where you've spent, not you personally, but you in the drug plan, you've gotten enough prescriptions that you've hit $4,020, you go into the coverage gap. So again, this is what I mean by if you have either really expensive drugs or you just have a really long list of drugs that tend to add up. So once it goes in, so for instance, diabetics are almost always going to go into the coverage gap because those drugs are high. So once $4,020 has been spent on your drugs, you go into the coverage gap. Once that happens, your share, your responsibility for your drugs, regardless in this year of whether they are brand or generic, your share is 25%. So that's what you're going to pay, 25% of the retail cost. So in some cases, you'll notice that it's actually not going to change because you were paying the 25% anyway. In some cases, it's going to go up because you weren't paying 25, so it'll go up. I actually have seen a few cases, it's very weird to me, where it goes down because you were actually paying more than 25%. So it goes down. But whatever the retail cost that that drug company has negotiated with that particular pharmacy, you're paying 25% the entire time you're in the coverage gap. Now, most people who go into the coverage gap do not come out. They just stay there for the end of the year, and then when the new year starts, we start all over again. But there are a few people who are going to spend a whole heck of a lot more. Like I said, cancer patients often do, people with immunosuppressive drugs often do, transplant patients, because their drugs are just astronomical. I mean, even more than just someone on 1 or 2 diabetic drugs. And I know that from experience because my dad, he's got expensive drugs, but they're not that expensive. But I have seen some who their drugs are just sky high. So in that case, when you come out of it, that means you've spent out of pocket $6,350. And that is when you exit the coverage gap. And now your copay, your coinsurance should drop to 5% of the retail cost of the drugs. Now, I've seen people who it's taken months before they ever hit the coverage gap, so they might only be in it for a couple of months. I've seen some people mid-year, hey, it's summer, hey, you're in the coverage gap, and they just stay there for the rest of the year. I have seen people, because, again, they've got those really expensive drugs, where the minute they entered their plan, they were in the coverage gap the very first time, because the very first time they got their drugs, it cost over $4,000, and then the very next time they got their drugs, they had already spent well more than the coverage, that amount, and they went to catastrophic almost right away. So again, it really is going to depend on which drugs they have and which plan they're on as to when they may go into the coverage gap and if they come out of it.
And if the pharmacy tells you there is a better price just purchasing it out of pocket, not through your Part D plan, does that count towards your true out-of-pocket costs?
Yes, make sure you get the receipt and submit that to your plan so that they can tack it on to your true out-of-pocket cost.
Does hospice medications fall under Part A or underneath Part D?
Your hospice medication should be under Part A. Hospice, yeah, should mainly fall under Part A. Most cases, you're not going to pay for hospice unless, you have to go into respite care. Then you might pay up to 5% for your hospice care drugs. Now, the only time that may be different is if, let's say, I think we were talking about this a couple of weeks ago on a webinar, let's say you had to go to the hospital for some reason unrelated to the terminal illness that you have, then the drugs you get for that purpose may fall under Part A possibly. Well, that's still Part A. What am I saying? Well, it may not be hospice covered is what I'm trying to say. So there may be a few exceptions as to why or why not it's covered under the hospice portion, but in most cases that should be Part A.
Yeah. You may pay up to $5 towards your hospice-related medications.
But $5, not 5%. Thank you, Ryan.
Yeah, you're very welcome. When providers send in requests for prior authorizations, is the coverage of the drug effective immediately upon approval or the first of the following month?
I think that's going to depend on the insurance plan when they tell them that's going to be, because what you're doing is you're getting a coverage determination saying, hey, I need this person to get this filled. So if they agree to let them fill it, then it should be for whatever time period they say that this person's allowed to fill it, whether it's for a one-time exception, a 3-month exception, or for the rest of the year. So it should be from the time they say, yes, you can go fill it now.
Yeah, I concur with Adrienne. There is the distinct possibility that you would fill that prescription and have to, resubmit that and receive reimbursement while you were waiting on that prior authorization for you to pay more and then them reimburse you. But once you receive that approval, it should be an immediate thing. But not everybody does struggle with communicating with each other in a very timely manner at times. So I would not think that having to submit a reimbursement would be out of the question or totally out of left field. Have y'all heard anything about insulin prices going down in 2021?
Well, I know it's in the news that they have been making some changes as to and asking different plans to participate in lower cost sharing. I don't know, Ryan, if you've seen anything where we have something definite as to when that'll be effective or how much it'll be, but that is definitely making the rounds as to trying to get those prices down. Yeah,
if I'm not mistaken, I think that back in March that was really been put out that they were going to put a cap on drug makers and private insurers who managed Medicare drug benefits to try and test out new pricing for next year. The specifics of all of that, I'm not totally 100% on. I think that because we're still fairly, since that's been a big focus for fairly a short amount of time, and then the COVID-19 sort of pandemic sort of exploded around the same time that I really started to see a lot of that pick up. I'm not sure, where we are on that, but I think that what they're kind of looking at right now is having sort of a set price for insulins and things like that, but I'll try to also do some research on that and try to keep an updated stand on how everything's going. But it definitely is something that has been put out on the table that, from what I understand, is something that they're going to try and address within the next year or so. So I'm hoping to see a change in those insulin prices. As anyone who's been associated with the program or anyone who's worked with a Medicare recipient will tell you, it's one of the two medications that we see the most often and is the most expensive is insulins and respiratory medications. So, you know, if they do end up getting those insulin prices down, I think that it would be monstrously beneficial to a lot of Medicare beneficiaries.
And Ryan, you mentioned something, that's why I add to this slide. It reminded me, I meant to say it earlier. When I was talking about quantity limits, this is typically one of the ways plans manage access. And you may have a drug that plan that limits you to, you know, a 30-day supply. Because of the public health emergency, they actually are loosening that restriction unless it's a drug that they consider could be unsafe, like an opioid. But let's say it's not, you know, the limit wasn't because it was unsafe, it's because it was costly or something, and so that's why they limited it. Because of this, they want people to be able to get a 90-day supply so they don't go to the pharmacy as much. So that's one of the things that that's been loosened during this time period is the quantity limit. Also, some prior authorizations, depending on the drugs, might also be loosened in order to help people get better access so they don't have to go to the pharmacy as often or go to the doctor as often. So, you know, definitely be aware of some of those changes. But that's something, and we'll probably talk more about that tomorrow as well with the Medicare Advantage plans. But, you know, those are just some of the things that they're doing for this time period that we're in the public health emergency for the coronavirus.
Yeah, and it does look like that Helen shared a news story from a few months ago in regards to those insulin caps. So if anybody is interested, it is down there in the chat. Somebody did ask why the big difference in cost of Part D plans.
Well, you know, I think as was mentioned earlier, it's insurance and it's a business. So you're going to have some plans that are as monthly premiums are as little as $13.20, and then there are some that are well over $100. There are some differences, of course, in which prescriptions they cover. You know, again, I mentioned that they do have to cover every class, but they don't have to cover category, but they don't necessarily have to cover every drug in that category. They just have to cover a good range. So it may be that there's a plan out there that's super expensive, but it's because they cover some really super expensive drugs nobody else is going to touch. And so that may be one reason why they are high. Another reason is because they're business people and that's what they do.
and this one probably will be a fairly easy answer, Adrienne. How does Part D address coverage when one is in the hospital under observation and not as an admitted patient?
Now, I believe with Part D, usually that's still going to be under your Part D, especially if it's like a drug that you normally take anyway. I know my dad will bring some of his drugs to the hospital with him, and those would still be done under Part D, or if they did have to give it to them and it turns out it should have been Part D, I think they can submit the claim or get a reimbursement or something like that. If it's something that's part of the outpatient treatment, however, that should be under Part B. So this isn't something you take every day. You're in there under observation, but they feel like while they're observing you, you need this in order to be well while you're sitting there, then that should be under your Part B.
Yeah, Part D would not address that issue at all. You know, that is something that you need to make sure of when dealing with your parts A and B. You need to try and make sure, am I being held for observation or am I being admitted as an inpatient, to make sure whether your Part A or B cover you. But for prescription drug coverage, whether you are held for observation or whether you're admitted as an inpatient, when you get out and pick your drugs up from the pharmacy, that is when Part D comes into play. So in terms of the differentiation between an inpatient and observation, Part D would not address that. Now, does anybody have any more questions before we stop the recording? Of course, you can feel free to ask any questions once the recording stopped, but I want to give anybody an opportunity to ask any more questions. Okay, I'm going to go ahead and stop the recording.